Welcome, everyone. We're going to jump right in. I am Brooke Crouch. I'll be moderating this conversation with you guys today. I'll also be speaking, and we're going to start with three people that will take turns going through different information. Dr. Irene Hilton is on. She's joining us virtually. She'll be starting. Dr. Hilton, I'm going to go ahead and send it your way and let you get started.
Thank you very much. I'm assuming I can share my screen.
Yes, you should be able to share your screen.
Okay.
We can see it.
Perfect. Okay, great. Thank you very much. Well, welcome, everyone. And thank you so much for attending this conference pre-session on what is teledentistry. My name is Irene Hilton. I'm the dental consultant for the National Network for Oral Health Access. And I'm going to spend 15 minutes just doing a little background on teledentistry, and then just touch on some of the applications that we are doing in HRSA federally funded health centers. Let's see. So I have no conflicts of interest to disclose. So again, what is teledentistry? It depends on who you ask. These are three definitions of teledentistry that I pulled from our main source of information now, the internet, the Wikipedia definition, the American Dental Association's definition, and the American Teledentistry Association's definition. And I actually like the Wikipedia one, the first one, which says it's the use of information technology and telecommunications for dental care or oral health care, if we really even want to expand it more, consultation, education, and public awareness. And if you think about the history of teledentistry, and to say that the other definition just elaborate on that more, but basically it's the application of, again, information technology and telecommunications, whether it's healthcare, if you think of telehealth, and then teledentistry as a subgroup of that, because you can also use telehealth for behavioral health and basically any health discipline. So as I wanted to say, and I'll say in a minute, in terms of the history of teledentistry, when you think about the word telecommunications, when teledentistry first started in 1994, what was telecommunications back then was dial-up. It was dial-up, no pictures, this information lines going through your very slow screen in one font. So as the technology has evolved, the potential of teledentistry has also evolved. And I want to spend just, again, a couple of minutes talking about these key terms, and you're going to hear the speakers that you're going to hear this afternoon will be talking about the way that they and others have examples of how they're utilizing these different types of teledentistry. So, for example, the first definition is synchronous. So synchronous teledentistry. So you can think of that as being real-time live encounters between a provider and a patient. So, for example, those of you that are there, actually, even whether you're on virtual or in person, if suddenly in a couple of hours after dinner, you start to get a toothache, you will be able to go online. And if you Googled, teledentistry consult, for $79, you could get a real-time virtual consultation between you and a dentist to discuss your toothache. So that's an example of synchronous. So again, it's got to be real time. Both people are in real time. Then you have asynchronous. So asynchronous is where usually the asynchronous works where some provider is collecting information in one location and then transmits that information somewhere into the cloud or somewhere else. And then at a later time, and it could be a couple of hours, it could be the next day, another provider, usually we'll say the quote billable or the diagnosing provider or the consulting provider, will look at that information and make some kind of review or diagnosis or assessment. So there's a time lag between the time that the information is gathered and the time that the information is, we'll say, utilized. Again, in terms of patient management. So that would be asynchronous as opposed to synchronous, where again, the information is both gathered and reviewed and diagnosed, at the same time. So that's asynchronous and synchronous. Remote patient monitoring, again, is another application of telehealth. It's at the moment in dentistry, it does not have a lot of application yet, but you could see potentially, again, depending on what technology and science brings us in the future, it could have an application. Now, in medicine, let's say remote patient monitoring would be if you have high blood pressure and your PCP sends you a blood pressure cuff to your house, and you take your blood pressure 3 times a day, and those readings are automatically sent, via telecommunications to some warehouse, AI warehouse, where there's an algorithm that is actually kind of monitoring all of your readings. And anytime, and it's been programmed to when you start to deviate, beyond a certain standard definition, maybe your blood pressure goes up by 5 points and it's consistent over time, it will trigger an alert that, again, either goes to you or your primary care provider, and then they call you, or someone from the office calls you and asks you if you're taking your meds or you're eating more salt or whatever. So that's remote patient monitoring. And perhaps someday in dentistry, we'll be able to do the same thing if we have tests or strips, with saliva and things that can tell us whether or not we're in active, let's say, caries phase or active periodontal disease phase from information, but not yet. And then mobile health is, and any of you that are using, let's say you have MyChart as as part of your electronic health record, and you've used your computer or actually your phone. Let's say you've used your phone to access, or your iPad to access your medical, your test results, or to make appointments. You're doing mobile health, which is again using mobile technology to engage with the healthcare system. So these are our general definitions for today, our key terms. So I just want to show this for a minute. So if you think about it, so at NOAA, again, is the organization that I work for, we view teledentistry, and again, we work in health centers, federally funded FQHCs. We view teledentistry as one piece of this total healthcare delivery system for oral health equity, which involves, multiple applications, again, of which teledentistry is just one piece. It can involve the virtual dental, again, the synchronous teledentistry piece, the virtual dental home, healthcare, oral healthcare that's delivered in the primary care setting, mobile dentistry, the use of care coordination, workforce innovation, and the traditional surgically based dental office. These are all pieces. So teledentistry is one of the tools that, again, in this ideal system that hopefully we're all working for, if everything aligns, where again, teledentistry has a role. It has a very, very important role to play in providing services, especially to our most vulnerable populations. So again, just the brief, and this is very simplified, and I'm sure I'm going to miss something, timeline of teledentistry. So again, most of you may know that it was in 1994, the Total Dental Access Project was within the Department of Defense to try to, again, get consultation, improve consultation and oral health care, dental care for soldiers that were out in the field, far. And so again, they were trying to communicate and communicate with specialists, let's say, that were off-site. Now, again, as the technology has evolved by the early 2000s, which would have been like a decade later, we started to see in a teledentistry consult. So it's real time. So usually it would have been where a dentist was in one office with a patient and is consulting with another dentist let's say at a university about the patient. So usually it was a consult for specialty dentistry, but there's basically like two dentists one was with the patient, one was not with the patient. Then in 2010, we had the virtual dental home model, which was developed by Dr. Paul Glassman, who at that time was at UOP in San Francisco, which is an asynchronous model where, again, you have hygienists go out into the community. We'll talk about it a little bit more later. And then the diagnosis is done later. So it's an asynchronous store and forward model. A few years later, by the middle of this last decade, we started to see commercial applications of teledentistry. And by that, I mean, you did start to see both synchronous. So again, the development of, well, actually, mostly it was in asynchronous. I'm going to, without naming specific company names, we'll just say that there's a company that is now, started up around this time in the middle of the last decade, that where you can either go to a location and get scanning done of your mouth, or they'll send a scanner to your house and you can take your own scans. And then that information is sent somewhere else and they can do your ortho diagnosis from that and start sending you trays, to do orthodontic treatment. So that's an example, commercial application of asynchronous teledentistry. And again, as the telecommunications has evolved, these new disruptive applications, again, of teledentistry and the commercial side start to take place. So in some ways, the commercial side was far ahead of, we'll say, the public sector until COVID. So with COVID, again, starting in March of 2020, when all the states applied individually for their HIPAA relaxation waivers that resulted in teledentistry now, synchronous teledentistry now being able to be done by everyone, by any office in health centers. This is where now we have seen the emergence of synchronous teledentistry really in the last 2 years. So just a little bit word about why I would know all these things, and I'm giving this introduction. So again, I work for NOAN. We're the organization of all the oral health providers that work in federally funded health centers. We're over 30 years old, and we receive funding from HRSA to be their training and technical assistance partner for all things oral health. So since the beginning of COVID, well, even before, teledentistry, health centers was one of the locations where the virtual dental home model was piloted. And certainly since COVID, with the emergence of synchronous teledentistry, we have been studying early adopter health centers and the things that they've been doing with synchronous teledentistry. Because again, health centers are using it to try to reach the most underserved populations. This is a picture of our founder, John McFarland, in 1976. And you can see what the infection control and hairstyles were like back then. So just a word again about in health centers. So pre-COVID, there was some synchronous teledentistry going on. So here in the, you will have access to this presentation. Here's Finger Lakes Health Center in New York. They had one of those models I'm talking about where the patient would come to their clinic with their dentist, who would then telesynchronously with Eastman Center also in New York, about 90 minutes away, for pediatric specialty referral. So the patient needed to go to the OR. Instead of having to make 2 trips, they would do the pre-op consult via synchronous teledentistry, and then they would just go in to get the OR case. So again, there was 2 dentists present. Again, the virtual dental home has been piloted in multiple health centers, and is being done in health centers, except for when there was COVID. So again, it's the store and forward model. And California was the first state that passed legislative regulation to be able to do that, followed by Colorado. Now we have even more states. Again, a hygienist-based model where the hygienist goes into schools, preschools, skilled nursing facilities, congregate care facilities, and does prevention, and then takes the imaging and x-rays, and the dentist looks at it later and makes the treatment plan. The reason this model has not been more widely adopted is because of the scope changes required usually in the hygiene scope of practice. It has to be done at the state level with legislative change. So again, as we've seen from COVID, now we've added all of these other applications. These are all applications of teledentistry synchronous that we have seen since COVID. Again, using it to do prevention with patients, to do full comprehensive exams on children 0 to 5 who do not need x-rays, to patient administered care, self-management support, the triage of emergencies, and trauma and acute infections first to determine if it's appropriate for the patient to come in or not, or even begin medications, case management, care coordination. All these things are now taking place in health centers because of the allowing now of synchronous teledentistry. So here are some resources. These are NOAA's resources, the work that we've done with health centers, our teledentistry users guide. Again, it goes into more detail on specific case use. There are many, many other resources on teledentistry. I wanted to focus on this one from the Association of State and Territorial Dental Directors. It came out last year. This is the ADA's reference on billing and coding teledentistry. And you're at the teledentistry resource conference, so there's plenty of vendors to visit that to increase your knowledge of synchronous and asynchronous teledentistry tools, software, and hardware. This is a website where if you are interested in synchronous teledentistry, we have videos. This is again from the San Francisco Department of Public Health, videos in Spanish, English, and Chinese that go over for clients on, for example, how to take intraoral photos of your child's teeth that you can then send to the dentist's office, how to apply fluoride varnish at home, self-administered, and other, again, it's just part of the teledentistry prevention and examination visits for young kids. So any questions about teledentistry in health centers? Here's my contact information and my colleague, Candace Owen, NOAA's education director. And with that introduction as background to everything else you're going to be hearing, I turn it to the next speaker.
Thank you so much, Dr. Hilton. And we will give this over to Jamie Collins. So we'll get the slides switched over. And I did want to share, we are going to, if you'll put your questions in the chat, we're going to break in just a little bit for questions in person. So if you'll just hold those until the end, we will get to them. Thank you again, Dr. Hilton.
Thank you, everyone, and bear with us while we get the slides back up and running for the next go round here. A little bit of my background is I'm a dental hygienist. I've done quite a bit with billing and coding, providing testimony to the ADA every year with the Code Maintenance Committee. I've been fortunate enough that I get to travel and lecture and interact with folks like yourself, as well as I do a lot with writing. When we think about billing and coding, and we think a lot about reimbursement, because the reimbursement aspect is really what makes us be able to continue to provide care. You know, as much as we would love to do dentistry for free, we can't. But we work forward on that part of it too. As I said, my background's dental hygiene. I do a lot with billing and coding. I do quite a bit when it comes to teaching, lecturing. I am, full disclosure, the professional education manager at Mouthwatch. So we'll just talk about this good stuff while we skip through that slide once we get it up and going. So when we think about billing and coding, we have to consider, as I said, the reimbursement aspect. And we have the CDT codes at our disposal, but I often hear from providers, they say, Jamie, I billed teledentistry and I didn't get paid. And one of the big things is, how did you bill for teledentistry? It's really important to know that teledentistry is our method of doing treatment. It's not a procedure in itself. It's the way we are conducting the care for our patients. And with that, again, our synchronous, our asynchronous are never a standalone code. So we have to consider that part of it as well when we talk about it. And it's always used in conjunction with our procedure we are performing. So whether it's synchronous, which is our live, much like we would be on Zoom, our real-time encounter face-to-face, as Dr. Hilton already explained, or our asynchronous, which is more of our store and forward. Teledentistry can be done very successfully in both manners and reimbursed in both manners. Think of the asynchronous as absent. Easy way to remember it. You do not have to be connected at the same time. But what we found with COVID too, a lot of our third-party payers are now reimbursing. So it's not just we're going to bill it and we don't get reimbursed. Now, do we carry this cost onto our patient? Many of them are doing it. Aetna, Liberty, MetLife, DentaQuest, Blue Cross Blue Shield, Delta, Guardian, Emeritus, just to name a few. But now also many of our state Medicaid is also reimbursing for it as well. They are seeing the value and that access to care. So they're reimbursing for that teledentistry. So now we have another model to not only increase that access, but we're also making things a little bit more streamlined and efficient. Because we can provide that evaluation through teledentistry. And then from that point, we determine need. Do we need to see them today or can we see them next week? So we're determining the need and the ability to do so. And then we think about the referral part of it as well. So not only when we think about referrals, we're looking at the aspect of medical and dental collaboration, which we're starting to see more of. And especially with such a focus on medical and health, overall systemic health, we're finding that availability to do that. So inbound, maybe our physician is going to refer to us for oral lesions, for consent for medical treatment ahead of time. Outbound, likewise, if we're seeing these patients, we know the incidence of certain diseases like diabetes is greatly increased. So now we're able to provide that referral out when we suspect that for care. And even with our, thank you very much, IT saved the day for me one more time. When we think about that outbound care, just as we would refer if we felt a lump on the thyroid doing our oral cancer exams, or if they have high blood pressure. If you suspect, you should refer. And it's very quick and easy to do that through a telehealth platform. Yep. Okay, now it won't advance. The arrow is, see, I'm not a Mac user. But it's important to know too, which provider is going to bill for the teledentistry aspect when we look at billing and coding. If more than one provider is involved, who does it? And it's going to be the one that is providing the evaluation and the diagnosis. For example, if I refer to an oral surgeon to get the evaluation through teledentistry, that oral surgeon should be the one that's providing the diagnosis and at that point, billing the teledentistry code. I often hear too that, well, we did it by phone. Is that teledentistry? No. So maybe you can screen via phone and determine do they need to be seen, but you have no audio or visual means. If we are connecting with a dentist who provides a consult with audio and visual means, maybe we're billing a limited evaluation or we're billing for a screening. At that point, we can also utilize our teledentistry codes, either synchronous or asynchronous. And now we have reimbursable codes. Another way that we often see it is through triage centers. And what happens is the patient contacts a triage center that's going to then forward it to a dentist for evaluation using those audio and visual means. So that call center will probably be billing for a screening. They're billing for that aspect because they're determining the need to be seen by a dentist. Now, the dentist, on the other hand, we're billing for our limited evaluation and our teledentistry codes. Same thing as I explained with the specialist as well. But something we do have to consider about it is a patient perspective. So 2/3 of our patients that were through this study that came out recently said they thought teledentistry or telemedicine made it easier to achieve their healthcare. 84% were very satisfied with their telehealth session that they did have. Where almost 80% also have the possibility of accessing the internet. It is not difficult and there's not a lot of equipment needed to conduct teledentistry visits. It's very impressive what a patient can capture with a smartphone. Very impressive. 95%, they said they either own a computer or a smartphone connected to the internet. So this is the majority of our population. And 7 out of 10 patients said they're willing to switch providers if there was a more convenient option. Telehealth makes it convenient to conduct that. So again, as I said, when we look at our possibilities, remember, it's always in conjunction with our procedure we're performing when we bill for teledentistry. We have our limited oral evaluation codes. We have our reevaluation codes, problem focused. We have our post-op visits. Many times when your patients come for a post-op visit, you don't necessarily have to have something hands-on unless you're removing sutures or there's a reason for an x-ray. Many times they come in and it's just a quick look, see, make sure things are healing as they should. That can be done through teledentistry. Now we're saving that chair time for production. We're making things more efficient and we're making it more convenient for our patients. In many instances too, the periodic exams and case management. We also have image capture codes that we're able to use. So if we are capturing intraoral photographic images, we can bill for those. Many of our Medicaid services are reimbursing for these, depending on the state as well. So we're going to use our procedure, our teledentistry code, and those additional possibilities, as I said, for image capture. It is important to know, though, when we're billing for it, where that little arrow is our place of treatment code. These are our standardized ADA claim forms. That code right there needs to be changed to an O2, which signifies that it was telehealth services. There. Kind of up close right there too. Again, that place of services O2. Let's think outside the box too. It's more than the traditional dental office. We're doing this in FQHCs. We're doing it in outreach settings. We're embedding dental into medical settings, whether it's pediatric offices. Working with Mouthwatch and working with Teledent, I work with a lot of different organizations throughout the country. We have hygienists in pediatric offices. We're putting a camera into the hands of a nurse practitioner who may be going mobile, or homebound, bedbound patients, special needs homes, oncology offices. Because now we can bring care to the patient where they're at. Mobile programs again too. Community outreach programs, homeless programs, school-based programs are huge. We know the majority of our children have had decay, and they show up in the nurse's office with a toothache. So why can't we have that school nurse have that camera on hand? We train non-dental professionals how to use an intraoral camera. It's very easy. Now they're capturing the data and they're getting that child to a dental home. That dental home, that dental provider now has the ability to bill for that and connect with that parent all at the same time, whether synchronous or asynchronous. So trying to keep everything on time as well. Let's look how an example of it. So we have a hygienist that's going to see residents in a long-term healthcare facility using intraoral camera and a laptop, capturing images, capturing the data, clinical notes, and going through a synchronous live meeting via teledentistry with the dentist for evaluation. It's not always profitable for our dentists to go out mobile to these. So now the dentist can be on site wherever they are treating patients normally within the clinic and connecting off-site. So how would you bill for it? We would have the assessment of the patient, possibly, because we're determining the need to be seen. Maybe the hygienist is billing this. We have our image capture codes. We have our evaluation codes. Is it limited? Is it a periodic? And we have our synchronous teledentistry code. So now we're following the reimbursement. We're making this a profitable model for all of our providers, our clinics, but we're bringing care to some of our most at-risk populations as well. My email is there at the bottom. If you have additional questions on it, please don't hesitate to reach out to me. I'm going to turn this back over to our moderator, Brooke, and we'll go from there.
Thank you, Jamie. That was great information. We will turn this, we'll change the slides over one more time, and then Dr. Zach Bryan's going to share with us. So give us just 1 second while we switch over.
So giving additional context, we are a nonprofit program in a larger organization in the Cary, North Carolina area. And most of our resources are focused in oral health policy advocacy. So that's what we'll be talking about today. So giving some context that you've probably seen in our other speaker slides, but where have we been? So we're going to focus today's presentation where we've been, where we are now, and where we are going. So where we've been, primarily prior to COVID-19, utilization of teledentistry was in community health centers, public health settings, mobile and portable dental programs. But as Jamie just mentioned, you're seeing those really expand both in provider type and service location. And our policy landscape was anemic at best, right? So if any of you all have heard presentations from me before, you know that I'm very direct and say it like it is. But our reimbursement, our legislative and regulatory environments really were not conducive and friendly to teledentistry pre-COVID. So what did COVID do? It opened a policy window for us. And so you'll see the window in the middle of the slide. Anytime a policy window opens, I can attest and assure you that you want to take advantage of it. So between 2019 and 2020, we saw synchronous teledentistry appointments increase by 30 times, which is extremely significant. And asynchronous teledentistry appointments increased 10 times. So COVID really was that accelerant to make sure that we utilized all services at our disposal to meet the needs of our patients and the communities we were serving. Since then, at least 17 states had added teledentistry laws or expanded existing regulations, primarily with scope of practice, to allow teledentistry services to be delivered more efficiently and effectively. And currently, over half of states, so about 26 states in the country, have codified teledentistry in their dental practice acts. Going off of what Jamie just mentioned earlier, too, in a survey that was done by CareQuest, 97% of patients surveyed were satisfied and willing to use teledentistry again. So I put this in only to make the point that teledentistry is not going anywhere. So we get questions a lot at the Oral Health Collaborative, particularly around other state advocate groups asking, should we really push hard on this? And my answer is yes, because we're not going to see those reversal of policies. Now, reimbursement is a different story, which is something we will talk about in a few slides. But in terms of how patients are expecting to be interacted with and how they are seeking care in their healthcare system overall, including oral health care, I don't see teledentistry really reverting back to even pre-COVID numbers. So this is also demonstrated here. You'll see illustrated that COVID-19's impact on the percent of patients who have experienced teledentistry. And the chart depicts 100% of patients who have used teledentistry, with a percentage in blue depicting those who experienced it for the first time during COVID. And then the illustration makes it clear that the dramatic increase in familiarity of teledentistry after the initial phase of the pandemic, the current phase we're in right now, has not decreased. So patients are still wanting to seek services for oral health care via teledental models. Around 30 states at this point have currently outlined in regulation or in state law the use of teledentistry in their statutes and associated regulations. What we are finding is variation across the country, particularly around how comprehensive that legislation or regulation is. And several states are missing key components, are now having to go back and revise. So I do some consulting across the US for other state advocacy groups looking to implement teledentistry. And one of the largest pain points that I have heard is they kind of miss the whole privacy, confidentiality piece to add in statute, which is really important. So standard of care, I'll say it again and again, is not any different, right, between in-person visits and virtual visits. So this graph here will show you the states that have implemented or codified teledentistry law. The ones that are in the lighter green have not. Those that are in the darker color have. So we're kind of a mixed bag in the Mid-Atlantic area. We're in the South, y'all. So we do tend to move a little slower in terms of our policies. And I can say that I'm a native Kentuckian. So where do we want to go? We really saw this shift, as I mentioned, during COVID. And what we're also seeing is that we're still playing catch up to medicine. So for those in the room or virtual, raise your hand. Does that surprise anyone? No, right? So dentistry always lags behind a little bit to medicine, and we're forced to play catch up. But I see that as an opportunity. I think it's really important that we take the reins in our profession alongside the communities we're serving to make sure that we model care after what they are seeking in terms of value. So some of the current policy challenges that we have. We're seeing lapsing COVID-19 era regulations. So the states that had extended due to emergency declaration are now reversing those declarations, and that includes their payment policies, particularly in Medicaid. So a lot of the Medicaid programs are now starting to grapple with, should we continue reimbursing for teledentistry? If so, what modalities? I will tell you what we did see, at least in North Carolina, is an early part of COVID-19, we did reimburse for telephonic visits, primarily for triage, and that has since lapsed. And I have heard very vehemently from our Medicaid agency that that is not coming back. And that's something that Jamie alluded to earlier in her presentation as well. So telephonic, I would say, is probably a long shot in terms of payment regulation. But we're also seeing states needing to play catch up and adopt their workforce and scope of practice. So under emergency regulation, state boards were able to extend scope of practice to make sure that folks were able to access care that needed care. And now we're seeing that we're reverting back to pre-COVID, meaning some of our policies around scope of practice preclude the efficient and effective use of teledentistry, primarily with dental hygiene. Payment is a huge issue, obviously, and something that's not discussed often is the digital literacy landscape. So we're often asking folks to engage in a process that they're not too familiar with or maybe comfortable with at the outset, but we can help them become more comfortable. So it's really important as you're engaging in teledentistry that you work with your communities to provide the education and support along the way. I'm going to skip slide for time here. A couple other things that we're seeing across the US is the push for national compacts, and that is to help define and be consistent on what does that mean? What does a distant site mean? What is the originating site? What is asynchronous? What is synchronous? All the things that Dr. Hilton spoke of earlier. But we're actually seeing states band together, particularly in certain regions, and state boards are leaning on each other to say, what is in your legislation that we could adopt? When we wrote our legislation for the state of North Carolina, we modeled that after the state of New York, California, Missouri, and Kentucky. So we took a multi-state approach to make sure that we were getting the best of all the states' language incorporated into our legislation. And I would encourage you, in terms of just general policy advocacy work, lean on other states, don't reinvent the wheel. So direct supervision rules, I mentioned earlier, hygiene tends to be the largest scope, the issue with scope of practice, and that's generally around supervision. So if that is indirect or needing to be direct, prior examination rules, does the dentist need to examine the patient prior to the hygienist delivering any service, whether that's preventive, diagnostic, or other? And that does obviously vary state by state. Payment. We don't have any payers. I'm not sure if they're online, but I don't think we have any payers in the room. I don't want to make anyone's head explode, right? But payers in general are not very receptive to payment parity. So meaning that the service that is rendered, whether that's the modality through teledentistry or an in-person encounter, are paid equally. So there should be, in my opinion, equal payment for that service. It shouldn't matter the type or modality in which the service was delivered. And there is a lot of data and evidence. If folks are interested, reach out to me after and I can send you the literature, really demonstrating the efficacy and safety of teledentistry, that it's the same quality of care and often higher quality of care in terms of diagnosis than in-person visits. Digital literacy, I mentioned earlier, broadband access does still remain an issue, particularly in some geographic areas across the country, the Appalachian area being one of them. It's really difficult to get broadband in some of the mountainous areas in the state of North Carolina, Tennessee, Kentucky, et cetera. But there's movement to make that more accessible through satellite-based high-speed internet. I will tell you, I lived in the middle of nowhere in the Upper Peninsula of Michigan for many years with satellite internet, and it did not work. But now there really is this push to make sure that we have digital access to everyone. So the future, I really see it as teledentistry as being at a crossroads. So we have an opportunity, and it's really important that everyone takes the opportunity to push policies forward, whether that's in legislative environments or regulatory or in payment. The only way for us to be able to advance and continue pushing teledentistry as a viable option is to make sure that our collective voice is heard. All right, I think I saved us a little bit of time. I'm going to go ahead and turn it over, Brooke, to you for the Q&A from participants.
Okay, so I don't see a lot of questions in the chat. If you have any questions so far, if you'll go ahead and put them in there. What about our in-person? Does anyone have any questions that they want to ask at this point? If not, I kind of move for us to kind of keep moving forward because I'd love to have as much time at the end for our panel discussion. I think that's going to be a great time. So I am pushing for us to just go ahead and move forward, which will lead to my presentation. So if you guys have any questions though, while we're switching out slides, please put them in the chat or stand up and ask it out loud. Okay, so I'll get into my part. And it looks like everybody on virtual can see our slides, so we're good to go. I will give you a quick introduction. I'm Brooke Crouch. I'm a hygienist. I've worked under remote supervision. I'm based in Virginia. So I've done a lot of work. I've worked in mobile and teledentistry. So I'm going to be going over a lot of use cases, workflows, things like that today. So let's get started. I have no disclosures or anything to announce to you guys. Okay. So we talked a lot about synchronous and asynchronous. I've kind of got the codes listed there again to reinforce what Jamie was sharing with us when it comes to it. But from a provider standpoint, it's whichever way you do it, whether you do it synchronously, asynchronously, the main thing is that we just need to continue to think of teledentistry as a treatment option. It's an option for our patients. It is something that we have to be super innovative when we're trying to reach our patients. So I think of teledentistry as a communication. It's a way for us to communicate with our patients. It allows us to, provide the chair time for treatment and really save them time, cut down on in-person visits if we can do something through teledentistry. So we're going to go through a lot of different workflows, places that can be done. But the main takeaway and is always what I'm trying to get across to you guys is that it's something that it is a treatment option for our patients. So whether it's synchronous, asynchronous, we're going to look at both models again. We've heard from them, from all of our presenters on that. But with our goals, we're looking at what are our goals with teledentistry, telehealth. We're looking to improve access to care for patients that may not get it otherwise. We're trying to, be really innovative and try and how we can provide care to those patients. We're trying to, align with their needs. But the main things there is that we're trying to reduce the amount of time people are away from work, especially now. That was the case when, with COVID and everything too, when people were using teledentistry fairly frequently. But everywhere's short-staffed. I mean, everywhere you look, whether it's a dental office, whether it's a restaurant, wherever you look, people are short-staffed. We don't want them having to be away from work any more than they have to be away from work. We also are looking to increase patient acceptance, and that's where I believe very strongly that teledentistry allows us to communicate and build trust and confidence with our patients, which then helps increase patient acceptance. And we'll talk about some ways that that can be done. Again, we're still trying to reduce emergency department visits for dental issues because that continues to happen. Even, now it's the last place we want people going for a dental issue is the emergency room, but it still happens. And then reducing cost and PPE, of course. So a lot of goals with teledentistry and offering telehealth, but the majority, again, is that we're just trying to get as much care as we can to patients that need it and make it as easy as we can for them to get the care. So this is just some more information kind of looking at emergency use and teledentistry and how that can help here. We still know that more than 2 million visits are go to the ER for dental pain. And that's a lot. That's a lot of people that are still accessing the emergency department for a dental issue, which we know they still don't get the dental issue addressed. They still need to see a provider. Sorry. I talk with my hands a lot. So they still need to see a dental provider. So they're still not having that need met when they're accessing the ER for a dental issue. We know that uninsured and Medicaid patients tend to seek it more frequently. Women ages 21 to 34 tend to be the highest users for the ER for dental issues. And then the cost. I mean, we just talked about cost savings, and look at the cost. An average cost to the ER for a dental issue could range anywhere from $400 to $1,500 versus coming to see us in the dental office where that might have only cost them $90 to $200 for treatment. And then we would have treated the actual issue. So huge opportunity there. We're going to look at a bunch of different workflows and a bunch of different models as we're going through this information, but this is just some. I mean, if it were up to me, I would have an intraoral camera in everyone's hands, medical, dental, whatever it would be, school nurses, of course. So there's a lot of opportunity. These are just some of the ones where we tend to see our safety net and our public health models implementing teledentistry. So we've got like our state health departments, FQHCs, our dental and dental hygiene programs, free clinics, and even our tribal health facilities. So there's a lot of opportunity. The public sector tends to be much more open and innovative when it comes to using teledentistry. So there's all different kinds of ways that this can be used and implemented. If we're thinking about integrated care models, I mean, again, the opportunities are endless. Our nurses, they are great partners for us to train them on how to use the intraoral camera. It's so easy, like Jamie said, super easy to use an intraoral camera. And it just depends, like each model is going to be very different on whether you're looking at a synchronous or an asynchronous model. Of course, if it's a school-based program or more of a public health setting, we might be doing an asynchronous model there. And we're going to hear some great examples in the panel discussion this afternoon too. But it's going to be very dependent on the setting as to what that looks like for teledentistry. But some examples for integrated care would be medical settings, especially if dental is not co-located. So, in a lot of our FQHCs, dental is co-located and they're under the same roof. But if they're not, that's a great opportunity to think about teledentistry. There could be, especially like with our FQHCs, if there are certain populations, whether it be HIV clinics or some of our diabetic patients, how can we work with those groups to use teledentistry to integrate to make sure those patients are receiving their oral health needs and that those are being met because they're high-risk populations. I mean, that's just some examples, but OBGYN offices, again, we know those patients are high risk. They need to make sure that during their pregnancy that they're getting their teeth cleaned and that everything is healthy there. So that's another great opportunity. And then again, nursing programs and working with dental clinics. So we do have even programs out there where hygienists are working in the mobile setting and they've got nursing students coming along and being able to see how that looks and how to use an intraoral camera. So very innovative ways there. Okay, so this was my setup. So where this is going to be mobile clinics, but it's also integrated. So if you're thinking about mobile clinics and what that would look like, you might think about, long-term care facilities, school-based programs, Head Start programs, homeless shelters. The list is really endless. So you can think of different ways that you could take mobile equipment, but this is actually an integrated model as well. So this was my setup when I worked for an FQHC in Virginia. And we bought all of this equipment to start a school-based program. And that was January of 2020. So COVID stopped all that. We had all of this brand new equipment that was just sitting there. And so, I'm thinking, well, let's take it upstairs to pediatric medical. We've got peds up there. Let's go up there for the well child checks. There was an empty space. So I took my chair, which you can see there, my nomads back there for taking x-rays, my mouthwatch cameras in that picture. And I would sit up there. And so when kids would come for a well child check, I would go over, and if they didn't have a dental home, I offered to do a cleaning, preventive visit. I would capture the images and then I would send them to our dental office. So we were practicing asynchronous, but it was great. I mean, it was great in the fact that even if they had a dental home or they weren't due for a cleaning, I was able to go in at their pediatric well visit and discuss oral health. And that sends a message to a parent that I'm here for my child's well check and there's a hygienist coming in to talk about this, which is what we want. We want them to see that integrated model, that integrated care. Dr. Hilton spoke earlier about hygienists being in the medical setting. Absolutely. Absolutely. In this particular model, like I said, it worked because we were co-located, so I could be there. And there was actually an instance where I was able to see a kid who was having an issue, having a lot of pain. I was able to do his cleaning, take his x-rays. He came back later that afternoon and we were able to extract the tooth. So that's just a perfect example of what it can look like. But it just takes a little bit of innovation, buy-in from everyone. And I would tell you that this is a perfect model. It was great. How many parents took me up on it? Not a lot. That's the only thing, it wasn't it wasn't utilized as much as we would have hoped it would have been, but great example. And then of course you've got your for-profit and commercial models. So you've got opportunities for teledentistry there, your private practice. You've got some at your door dental services, mobile clinics that are for-profit, and there's a lot of benefits to that. So I think that our panel discussion is going to cover a lot of different things. And I think that that's going to be great for everyone to hear how they're doing things. And then we've got corporate dental services where, mobile clinics might come and visit an entire corporate office and provide cleanings for everyone so that people don't have to leave work for their dental visit. They can go down to the parking lot, go to the mobile van, have everything done, and go back to work. So again, that's a corporate model. I do want to take a minute to talk about private practice. So I mentioned that, and it's not even necessarily just private practice. This really could be any model, but think about your new patients. And if you think about your new patients that are coming to you, whether it's private practice, public health, whatever it is, the majority of that time of that appointment is spent talking about their entire dental history. I mean, if you think about a new patient appointment, the majority of that appointment is spent with them telling you about all the things they've had dental done. Why aren't we using teledentistry for that? Why are we not, as a part of their paperwork before they come, having someone that's dedicated to capture that dental history and let that patient tell you if they want to take 15 minutes to tell you about every bad experience they've had? Cool, that sounds great, but let's do it through teledentistry so that when you are here and you're in the chair, we can maximize the time that you have with the hygienist or the dentist. I also think that in that same regard, those new patients, they are coming to you and we are in full PPE still. So they are not seeing what we look like. They don't know. I mean, and it can be very intimidating, especially if they haven't had a dental visit in a long time. So in Virginia, we just passed Medicaid for adults last year. So a lot of adults seeking dental that haven't had it. And it's intimidating. So if they were able to meet with someone face-to-face through like a synchronous, that would be a synchronous visit, but have 15 minutes to put a face, with the name, know where they're going so that when they come for that appointment, they can say, oh yeah, that's right. We talked on our Zoom or our call. And it just builds patient trust. It's communication. You are reinforcing communication. You're building a relationship with that patient. And then I also think that after like a post new patient exam through teledentistry would be ideal. Those patients come and we oftentimes will send them with a treatment plan that's 2 pages long. And what do? Nothing. They might come in for their cleaning. They might come in for scaling a root planning procedure, but they're probably not going to follow through with all that we recommended from them. Why do we not have that same person that they met with their new patient before they came for their new patient say, hey, it was great to have you in the office. We're excited that you're coming for dental. Let's schedule a 2-week follow-up. So let's just touch base in a couple of weeks. We're going to send you with a lot of information and I want to answer any questions you have. And then follow up with them again through synchronous to say, have you had a chance to think about all that we covered at your new patient exam? What questions do you have for me? How do you feel most comfortable getting started so that we can make sure that we are addressing your oral health needs? A lot of opportunity there, so much opportunity. And I think that's really, again, where we're building trust, we are building relationship, and then that will ultimately increase patient acceptance. Yeah.
Who does that call?
So I feel like that could really be whoever the office designates. Right now, so many offices are short on hygienists. So it could be an assistant. It could really be, maybe it's a front office. It really, I think, would depend on the setting. I think it's just going to depend on the setting. It wouldn't be the dentist because that's just not going to be the best use of his or her time. But I think it needs to be someone that person's going to see on a regular basis. And then specialty care, this is just kind of highlighting the fact that we can use teledentistry to expedite any referrals that we may be making. And these are just some examples. I do think that when we're talking about all of these different models, just remembering that when we are, especially if it's a mobile program, a picture's worth 1,000 words. And a lot of times, if it's a school-based program, the parent is not there. If it's a long-term care facility, the loved one or caregiver, whoever is not there. It's very easy. I worked in a school-based program where we did not do teledentistry. And my options were to see the patient, see the major needs, call, get someone on the phone, tell them over the phone. And what I usually got was, okay, we'll try to make an appointment. If I had sent pictures to say, I saw your child in the school-based program today. We've got some major things we need to address. I've sent pictures to you. Have you had a chance to review them? Because there's no denying when you see pictures of some of the things that we see in those settings. This is just an example of a workflow, and this is from the Virginia Health Catalyst. You can find this on their site. A workflow is going to be very different depending on the program. So it's there as a guideline. You can reference that just to get an idea, but every workflow is going to look so different depending on the setting and the program. But you guys can reference that from the Virginia Health Catalyst as well. So some challenges faced because of course, it's not easy. It's not easy. As simple as teledentistry is, implementing it is not that easy. So just some of the things that we can face, broadband support is an issue in Virginia as well. There's a lot of areas in Virginia that's very difficult for people to get adequate broadband support. There has to be a level of some technical skill. Although I think, Jamie, the information you shared this morning with those stats, very helpful to see from a patient perspective that they felt comfortable with telehealth visits, but it is good to remember that there has to be a level of technical skills there. If translation is needed, that can make it a little more challenging. Time coordination can be tricky. So just depending again on the model, if it's an integrated care model, that's going to be a little trickier. Time coordination is a critical piece though. But the biggest thing is that team buy-in is essential. We can have all the ideas in the world, but if our provider isn't on board, it's not going to go smoothly. If your front office person doesn't believe in the ability that this has, it's not going to be as successful. So we need everyone's buy-in to make it successful. So just some last conclusions here. Teledentistry definitely provides a secure one-stop access to a dental provider, including a hygienist, helps address transportation challenges, especially now. Gas is expensive and people truly are making decisions on where they want to go and what they want to spend their money on. So if they are going to have to come to see you 3 or 4 times for a dental appointment, where can we cut down on their time? Where can we help keep it from being 3 to 4 times to just being maybe 2 times? Because we know teledentistry is not meant to replace the in-person visit. It's not. It's just meant to make it more effective and more successful. We know it can improve patient outcomes, but again, as you guys can tell, to me, it's just you're building trust with the patient, which can then help with their patient compliance. That's it. So thank you guys. We will, be heading into our panel discussion, but please, if you think of questions, put it in the chat. We will have some time at the end where we can, ask some more questions too. So if you think of anything you want to know from me, I'm going to check the chat actually really quick before we switch over. Yeah.
Regarding sending dental pictures, how did you navigate that?
With sending pictures to parents. Yeah. So we didn't ever actually get to that point. We never were sending that on. In the nursing home setting, we were attempting to do that. You basically just are going to have to get a good email address and find a good software system. Yeah, somewhere that you can get that to them.
I really like that idea.
And some of my colleagues that do that, when they take the images, they try to find a way to print them. So you could try to find a way to print them when you're on site, even if that meant that you buy your own printer. I mean, we're mobile, we're used to taking a ton of equipment. You could have a printer so that you have some way to take the images and then print them and give them.
If you're utilizing software, you have that patient portal that you connect with that parent, you connect with that caregiver or child patient. Upload those images. Likewise, we can share any of them. So yeah, they can see what you see. Now we're creating that. And they have access to it.
We use solution. We have to software. It automatically connects to solution. When you put the patient on your schedule, you can just use solution. You can actually drop it in from your file and drop it right in.
Our patients don't have internet access.
Right.
So even with our screen out watch, even if they don't, they can text message.
And I am going to read just a couple of questions that have come through in our chat before we get over into the panel discussion. Yes, definitely not forgetting about the rural health clinics out there. Absolutely. And then one question here, there was one here about, and I will probably hand this over to you, Dr. Bryan, regarding policy. I will let you maybe get to that one. I will say that there's another question, maybe we can answer this together, that was just asking about, and maybe on the panel discussion, you guys might talk about this, it looks like, but looks like there was a question about competition for telehealth services, that there seems to be, some competition with people wanting to offer teleservices like, let's say ortho, like teeth straightening and different more high revenue services. Are we concerned with anything and how that could impact our telehealth? So that could be a question for the group. Okay. All right. Yep, Dr. Coe, I see that with giving the mic for anyone asking a question. Okay. All right. So I'm going to turn this over and let you address this one.
Hi, Dr. Flores. It's nice to see you online. So his question is regarding policy. We now have an issue in North Carolina. Medicaid recently only advanced into permanent policy that provider-to-provider synchronous 9995 or 9996 or asynchronous is currently under review. All other codes for patient to provider will be sunsetting effective. So it seems like unless the patient has private insurance or paying out of pocket, the access to teledentistry is minimal, which does nothing to increase access to care for the patient in rural communities who, for example, have to travel long distances. Okay, so a couple things. So what he's referring to, and we've seen this in other states, it's not just North Carolina. So during COVID, the Medicaid agencies were reimbursing for what they would consider provider to patient or patient to provider. What we are seeing now is some Medicaid agencies are tightening that and saying we're only going to reimburse for teledentistry services done between providers. And that is something I won't talk a lot about here being recorded, but I'm happy to follow up, Dr. Flores, with you about our state in particular. But the rationale behind it is that they want patients to not engage with providers ever on site. So the concern is if they allow for direct payment of patient to provider, that it will not incentivize patients to seek care in a more traditional sense. So the one thing that I would say is a workaround is that providers are not just dentist to dentist. So providers are defined by hygiene to dentist. So I'll give you an example. If you're in a school-based setting, Dr. Flores, I know that you mentioned those in community-based settings, that service is still paid for, right? Whether it's synchronous or asynchronously provided. So if a provider, the hygienist, is in a community setting, a school, and then transfers those images asynchronously or synchronously to a dentist offsite to review, the exam, the assessment is still billable. So what they are not obviously providing reimbursement for is for a patient to upload images and then the provider review them for exam coding, for example. It's something we're working on. And then the second part's really important. So how can we get involved in policy advocacy if you have a similar issue in your practice, how are you working around it? Any advice? Yeah, let's follow up offline on that. But the other part is how can you get involved? People don't realize that the state board meetings are generally open. They have closed sessions if there's something specific that they're reviewing, but by and large, they're open. So you can go to them and you should go to them and you should provide your feedback and ask a lot of questions and provide solutions. So instead of focusing just on the issue, focus on solutions and offer that. The other thing is you can work with your payers. They want to build consistent relationships that are fruitful with their providers. If you feel strongly that there's an issue, you can reach out to them and have a discussion. Aside from that, there are ways that you can directly increase and change policy, not having to involve those parties by linking up with a legislator. So if you have a legislator in your district or you're their constituent, build a relationship with them, send them an email, call them, go visit them, discuss the issues. And I think the thing that people forget is they think that the state legislature that is charged with setting the Practice Act knows a lot about dentistry. They do not. So they're not content experts across all health sectors. So often, like in North Carolina, for example, there's not really a specific person that is a dentist, right? Or is a hygienist. So reach out to them, meet with them, talk with them, offer solutions, and build a rapport with them. So don't just come in and say, this is my ask. Ask them how you can work with them. We've seen that work quite successfully across the country, not just in our state. So that would be my suggestion. And then Dr. Flores, we can talk more about specific workarounds for North Carolina.
Okay, so with that, we will get ready for our panel discussion. Dr. Hilton, did you want to share your screen for that panel discussion?
Actually, I was thinking we could go to gallery.
Okay.
so that we can see, because some of the people are virtual.
Right.
I see two people in the room. Yes.
Yes, they're here together. So I'm going to put the mic over here. Is this good to be in this? Can you see? You can see them. Okay.
Yep.
I'm going to give the mic to them.
Great. And actually, is it okay if I just spend like 2 minutes responding to that other question, the one about what's happening in North Carolina and
Absolutely.
Zachary. You know what we've found is that, like anything, we're in a time and space right now with the disruption, in the technology and with COVID, has caused, like I said, this disruption with the synchronous teledentistry. We have so many, whether it was health centers or the commercial sector, people that just like jumped right into like doing all these like really, really interesting and useful things to increase access. And as was mentioned, there's so much of dentistry that does not need to take place in person. And what happened again during these last 2 years is all of those things have been explored and found out. But now that everything is kind of the new normal, payers who, at first, for the first 2 years, again, let's say they weren't paying that much attention, but with everything that was going on, the people didn't expect the innovation that has happened and what people are doing with teledentistry, like we'll see with this panel. And so now payers are basically regressing back to the mean, and what used to be, and it's because the innovation, they have not caught up with the innovation yet. And our system is set up, it's always limited what's there. Well, for healthcare in general, but for oral health. And so that's why you're seeing all this like contraction and stepping back away from payment and policy that was in place, at the beginning of COVID that allowed all this to take place. So really the question is, can you really put the genie back in the bottle? Things may contract, but eventually it's going to open up again because people know what can be done now. And speaking of what can be done now we have our panel who is going to go over. And so I'd like to introduce Julie Coe is is online. And then in the room, I believe we have Erica and Kiana. There's Kiana and Erica. And then Jackie, where is Jackie? Jackie is also virtual. Jackie, are you there? Okay, we see her. I wonder if Jackie thought maybe we were going to start, and maybe she was anticipating we were going to start at 12:40. Jackie, if you're there, would you unmute and let us know? Because otherwise, then is it okay then if we proceed and Jackie's not going to be participating right now? Brooke, your thoughts on that?
Sorry about that. I was getting a mic. I think we should go ahead and proceed. I'm going to shoot her a text also.
Okay, great. Thank you. Okay, so again, it's Irene. I'm back and I'll be moderating this session. And so we have a combination of 4 dynamic speakers. 1 is in private practice, 2 are from FQHCs, and 1 is from an academic institution that are going to be talking about what they are doing in terms of teledentistry. So we're going to round robin and vary the round robining. And so everybody will have an opportunity to answer. And we have a set of questions that we prepared to ask. So the first question for the panel is, please describe your teledentistry program, what you're currently doing with teledentistry. And so we'd like to start off with Erica.
All right. Hi, my name is Erica Slagle-Perry, and I'm the school program supervisor for the Community Health Center of the New River Valley, and we're an FQHC. We are located in a very rural part of southwestern Virginia called Giles County. We have an integrated medical and dental office within a high school. What we do, we use teledentistry within 3 ways. Basically, we have the standalone office where we perform oral hygiene appointments, and that information is then stored and forwarded to our dentist who is offsite in our main clinic about a mile up the road, very close. The second way is through our mobile hygiene van. We go to all of the elementary and middle schools in the area, and we perform mobile hygiene appointments. And again, we store and forward to our dentist. And we also use MouthWatch, the intraoral camera, for all of our schools. Every school in the county, we've given a laptop computer and an intraoral camera to them. And if a student goes to the school nurse or a faculty member for that matter, and they're having dental pain, then the school nurse then connect live stream with our dentist who is offsite. The student can get antibiotics that same day. We've gone through a lot of training with them, and it's very easy to use. They're very happy with it. Thank you.
Thank you, Erica. And next, if we could go to Dr. Kiana.
Good afternoon. Dr. Robinson. I am the dental director for Charlotte Community Health Clinic here we're in Concord, but in the heart of Charlotte, North Carolina. We are one of two FQHCs that have dental in Charlotte. We are using teledentistry, as Dr. Bryant had described earlier. North Carolina just received or expanded the access to teledentistry. So we started in the height of COVID in April of 2020 through the North Carolina Oral Health Collaborative. We were offered a grant to purchase our teledentistry platform, because at that time, a lot of FQHCs was trying to what are we going to do with these extra people? So I am appreciative of North Carolina Oral Health Collaborative because they helped us jumpstart our teledentistry platform. So at that time, we started using teledentistry for emergency visits, triage. We could not open our office. We are located in the regional office of Goodwill of the Southern Piedmont region. And we didn't have the choice. They told us that they didn't want anyone in the building. So this allowed, one, my team to stay employed, two, to keep patients out of the emergency room. And then when we were able to open, we were able to provide those inpatient services. We also used teledentistry at that time with my dental hygienist. She was integrated into medical. Our medical office had blood pressure checks, drive-through blood pressure checks for their patients, checking sugar levels or glucose levels for the patients. And she would actually place fluoride. And so if they had a dental issue at that time, she would do a teledental visit with them and do SMGs, which is self-management goals. And she would do education, and she would do motivational interviewing. Once we were able to open and see in person, I still kept 2 days a week doing virtual visits and then bringing the patient in for in-person treatment. Now where we are, I have a new doctor on my team, so it opened up more space for in-person visits. But now we're using it for our school-based program. We're like Brooke, where we were offered a grant from the Duke Endowment in the fall of 2019. We were planning to go into the schools and everything shut down. So we just got into our schools in November of 2021. And now we're using, my hygienist has received her public health dental hygiene certificate. So she goes into the schools and we are doing asynchronous visits in our school system.
Thank you, Kiana. And now if we could turn to Dr. Julie.
Okay, I'm Dr. Julie Ko. I'm a general dentist. I spent many years in not-for-profit organizations such as academia, teaching, researching public health and technology. And about 4 years ago, me and my partner, a dentist, opened a private practice in Leesburg, Virginia. So it's a Loudoun County, so it's not like a little distant from the Fairfax County, which is a direct suburb from DC. And we are more kind of in the sandwiched a little bit between hustling, bustling Fairfax County and the Shenandoah Valley area. So that's where we are located. And then we have a brick and mortar business, just regular, dental office. And we have a mobile van, 28-foot medical trailer with 2 dental operatories. And we go to long-term care facilities and medical community clinics, which does not have a dentistry, and working with the foundations, Christian ministry organizations. We also have a home visit kind of a line. So we have a portable equipments, and then we go to group homes, the long-term care facilities as individual patients. And we also provide preventive services and diagnosis, as well as the fillings, extractions, and denture, those things. If you want to know more about, how we do things, you can go to our website, divadentistry.com.
Thank you, Julie. And I don't think Jackie's on yet, but when she gets on, we'll ask her to fill us in on her program. So let's go to the next question, which is, what are 2 to 3 things that you consider key to the successes you've had with your teledentistry program? If we could start with Dr. Kiana.
Yes, we had 3. One is that we were able to successfully treat patients. Some of the statistics that were given earlier about how patients felt like they were given adequate care. I mean, I could count on one hand, maybe from the pictures that my patients sent me, I might have I thought it was this tooth, but it was another tooth once the x-ray, once we took the radiograph. However, if you know your symptoms that a patient presents with, the accuracy is pretty spot on. So, we are actually able to treat patients and successfully get them out of pain, also offer antibiotics to keep them out the emergency room. The second one is able to build a platform with the help of my dental team, and they have embraced it. I have been lucky enough, it was only 4 of us, including myself. So there was really not a lot of opposition. But I know I've heard from other colleagues how some providers are just not with it, but it does work. It was less stressful, and we actually saw more patients. And now, we've expanded this opportunity to a school that is lacking access. We are in a charter school, which we found out doesn't have the same access as the schools under Charlotte-Mecklenburg school system. So, so this is what teledentistry has done for us.
All right, thank you. And Dr. Julie, some of the keys to your success?
I consider this is continuing improvement and continuing, working towards success. The few things I want to share is that as all of us learned, or are first to learn, during COVID, is that being flexible and be open and be patient and be persistent and follow your heart. So a lot there. And but we all learned, Kiana mentioned about her program kind of was launching right before COVID, and I purchased it with a big loan that mover trailer right before COVID. So I had to really learn that with the pressure of a loan, that being adaptable with these emerging situations, and at the same time really open where the demands are and where opportunities are open for you. So because all of us are here that are pretty much pioneers in this area, and we are talking a lot about mentality shift or change or even paradigm shift. And we work with the people who may not be familiar with each other's, the workflow or work content and knowledge skills, but we all have one good purpose: to help others and advance this, great momentum. So be adaptable. For me, originally I was thinking mainly about long-term care facilities. I'm indebted so much from my grandmothers, who sacrificed so much during Korean War. So that was my heart. I was ready to jump in. And then what happened, that the long-term care facilities just completely locked down for a long, long time. And I just had to learn that where the demands are and that how we can adapt. So, I had the portable equipment that there was some opportunities for dementia patients and homebound patients may not be necessarily, that are elderly people, but the people who had a trauma, so they have agoraphobia, so they cannot go out of their front door. So we made a home visit, learned so much from the process, and we continue to adapt, by having this brick and mortar business and as a hub for the dental home and the mobile clinic and the home visit. So adaptable to whatever environment and whatever opportunities it bring to that brought to you, and adaptable to emerging technology as well, because there's so much to choose, even intraoral camera. And then at the end of the day, what's the most user friendly one? That's kind of my main concept. And you just need to need to be adaptable to emerging technologies. And the one more thing I want to mention is really, and especially for this audience, relationship. We all know, not for profit, wherever you go, the relationship is everything. It's, at the end of the day, it's a human business, and finding good partners and then train each other. I think that has been one of the key to success. That all of us, can learn from. Yep.
Thank you, Julie. And I do want to lift up again one of the things you said about how really people on the panel are some of the pioneers in teledentistry. And so it's just great to listen to the things that you're doing, you have done. Erica, if I could ask you again, some of your keys to success.
Sure. So communication is so important when utilizing teledentistry. In my situation specifically, communication with the school nurses so that they understand how and when to utilize mouthwash. Communication with the student's family and their parent or guardian. This is what's happening. This is what we saw. These are our next steps. And our dentist, right? We need to train our dentist and our hygienist and our oral health advocates. We need to make sure that they understand the whole process of what's going on, or else they can't successfully push the program forward. Education is such a big piece to this. And once you learn it, it's so simple. It's so easy. The program is so easy, and it can be utilized in so many different ways. We actually use it for medical now too. We do use our mouthwash. We had a patient come into the medical the other day with a sore throat, and we were like, let's get Gabby, our oral health advocate. He said, "Oh, my tooth hurts too." We're like, "Gabby, come on over." So we were able to integrate that process right there. He had an abscess. He got his antibiotics. Got seen for medical and dental at the same time. It's a great thing, but you do have to have the buy-in from all stakeholders, from your schools, from your dentists, from your company, from your grant people, if you have a grant. Those are my keys to success.
Okay, thank you. I just want to double check. Jackie, are you on yet? Okay. Well, when Jackie gets on, we're going to catch up and ask her all the questions at once. So let's go ahead to our next question, which is, what has been the biggest challenge that you were able to overcome in implementing your teledentistry program? Your biggest challenge that you were able to overcome. We could start with Dr. Julie.
It's a pretty, loaded question. The biggest challenge that I was able to overcome. I see it more as a continuum, and the challenges, here and there. And one thing I can kind of rephrase a little bit is that I want to share the challenge I saw on example how it can be overcome. So I think it was kind of mentioned a lot already among the panelists about the relationship building and education and communication. That I know that many of the audience and then these conference attendees are not necessarily the dental professionals. And I want to kind of emphasize that how we can work together, whether you are clinical or you are admin or whatever leadership position you have. I have a person that, when we go out and it's logistically, it can be very challenging, getting the schedule correct and then make sure that people show up and the consent form, ready to go, and the translation oftentimes with underprivileged population. And for me, is my organization is for profit. My heart, that because of my background and where my heart is, that I'm not doing this just to make profits. But at the end of the day, I have a huge loan and I have a staff I need to pay. And I have direct costs, gas prices are soaring. I literally have to, make some ends meet. And when I go there and then see patients, it's a great day. But if the patients don't show up and then we prepared everything, we go there, and we are just idling. My staff are doing nothing. And then really there's a bad day. It's better to have that sweating day and a long day with full of patients. It's much better, And so that was kind of one of the challenges I heard a lot. And I just have one example of a lady, that from the community clinic in the Fairfax County, where mainly serving Spanish-speaking population. I'm guessing many immigrants. And they walk to the clinic. They don't have a good means of transportation most of the time. They walk to the clinic. And this lady, Didi, that she has been in that reception front desk area for 15 years. She's not, like a, huge, that the high in the hierarchy in that organization, but she's so passionate. She's, that bilingual, so Spanish and English, and she's bicultural. She understands Spanish-speaking people's challenges, but at the same time, she knows that to keep this program going is very important. Her role is very pivotal in making this run smoothly. So people get, that the care they need, and that they see the benefit of it, and then they spread the words, and then they keep coming. So what this lady does is they really build a relationship with one-on-one almost. She knows what's going on with the family, with the patients, and then she makes sure that they show up 15 minutes before, paperwork all done, and she get the intake, over the phone about all the medical history. You can imagine, that you have to speak in Spanish over the phone with somebody and then write down every little thing, but she does that, and then makes the program running so smoothly. And they may expand to refugee population from the Afghanistan, and they were featured in NBC. I just saw that her role, and of course, under a strong leadership too, but her passion, the difference that she made. So I only have an example of the relationship, and then we do, that our job with a whole heart, not just to do our job and just get by the day. And then even for profit, can make a difference in the community, even if some stereotype that that for profit is for profit. And at the same time, that more and more, the for profit people can join this community effort.
Thank you. I've lost track of my, Erica. Go ahead and share your challenge.
Sure. So our challenge, a large challenge that we did have was the technological hesitation of the school. The school nurses were firstly, they were very fearful to deal with dental issues. They're not used to it. They don't know a whole heck of a lot about it. You don't get a lot of training on that in medical school or nursing school. But they were very nervous about using a new program. We combated that with education. We had a breakfast and coffee learn, and they all came in and we fed them, we caffeinated them, and from there we educated them. Once they figured out how simple the program was to use, it was no big deal at that point. We also we had the school nurse coordinator be our official teledentistry champion. And once she was really involved and really was sold onto the process, she was then able to show her enthusiasm with her group of nurses, and that was extremely helpful in combating that. We just continue to maintain an open line of communication with everyone, and that's very important. I cannot stress that enough when using telehealth.
Well, one thing I've heard from both of you so far is having success by finding champions. Just notice that. Dr. Kiana?
For us, it's, as it has been mentioned before, it's the flexibility of basically overcoming workflow challenges at our school, and even when we first started with the teledentistry platform. So working with NOAA and ADA, we were able to participate in CELINT collaboratives and teledentistry collaborative. We learned about PDSAs, which is plan, study, do, act. So those help a lot. They keep you sane, they keep you calm, and help you displace that fear, because you still have, yes, you have fear from the nurses and other people you're trying to educate about this platform, but then that initial fear starts within yourself. And so PDSAs allow us to thoughtfully plan and do it, and then we can change it over time with that flexibility, because nothing is ever going to be perfect. And as the landscape is changing, as you heard today, we're going to have to change some more stuff, because I learned some things here today.
Mm-hmm, definitely. Okay, now let's move on to our next question, which is kind of a follow-up to this question. What are some of the continuing challenges that you're having that prevents you from taking your teledentistry program, to the next level? If we could start with Erica on that.
We're located in not just rural, but very rural Virginia. We are in the mountains right across the line from West Virginia. Broadband access is so limited there. I think there are two of the schools that we go into where we don't have internet capability. We just don't have it. So everything is saved on the desktop, and we just do the best we can and we push forward. Hopefully that will change one day, but that is a huge challenge for us.
Actually, circling back more sooner than we thought, Dr. Kiana, can you give us some continuing challenges?
Yes. One is being understaffed. I'm located in the heart of Charlotte. Charlotte is all over the map, all over the news. We're we're one of the most sought after cities to move to. Housing is an issue in Charlotte, so that means incomes need to go up. So we have I have an awesome public health dental hygienist, and we just got a contract dental hygienist, but we still need some DA2. So there's just challenges with team members, because in order for these programs to be successful, and in order for my hygienist to be able to serve the population she wants to serve, she needs help. She can't, and I keep telling you, you can't keep doing it all by yourself. She thinks she can, but she needs help. I feel like, we're in a rush to go back to pre-pandemic. And so, I'm in the chair, have my doctor in the chair, and I need time to strategically plan for our mobile unit. I'll expand on that one, or I'm probably entering into the next question. But I was so focused on getting this portable equipment, and we're going to get a Sprinter van, and I should have put all my focus, or my team and I should have put all our focus in a mobile unit off from the start. So our thinking process was kind of backwards, basically.
All right, thank you. And Dr. Julie, continuing challenges?
Yeah, I can list so many, but I will try to kind of narrow down a little bit. First thing I want to mention is that, like, other panelists mentioned, is about finding good partners with, that like-minded, with commonly share the purpose, I would say. So for me, for example, that finding a dental hygienist that I like, Erica, your model, that's what I want to do in this area. But we have 2 dentists, but it has been very difficult to find a hygienist who's really willing to, that they go into the area, maybe outside their comfort zone, and willing to learn this new environment and the technology and the different way of doing things. It has been very difficult, that I'm sure that there are some out there, but it's more about, that how the people with commonly share the purpose are connected. So, by having this kind of a conference and talking with the people, and hopefully that we can find good partners, but that's kind of the main thing to me. And the other thing I want to kind of add to what's already discussed is that awareness of teledentistry and what we are capable of doing now, and in conjunction with telehealth. Because I think more and more patients, I heard that they heard about telehealth, and then they sometimes have, doctor's visit with tele. So they have some awareness, but because the dentistry has been done for a long time in a more mini surgical suite type philosophy. So for patients, even when I show them, this is a camera looking thing, this is x-ray, that we can take x-ray, and then we can do this. So our model is really not just preventive care, but do fillings, that the extractions and the dentures and things like that. That makes it much more complex, but that's the goal, and that's what we are doing. But awareness, that the patients and the partners and the medical facilities, admin staff, and even insurance companies and professional liability carriers, that they are not there yet. That the technology and that maybe policy a little behind, but also culture, mentality in people's minds are way behind. So I had to show them a lot, that to demonstrate a lot and speak about it, show video to finally, have a little clicks from their minds. So by having, good collaboration with our medical partners and the other healthcare that partners and patients, and some sort of advocacy organizations such as the Alzheimer, Association, for example, that we can kind of create some momentum, not just, that buzzwords that we are talking inside dentistry, but more about outside dentistry, that we are talking about these things, what's possible and what we can do together.
Yeah, I just want to second what I heard from a few of you about workforce. And I think we've seen, certainly in the work at NOAA, but also from the ADA, that workforce is really a challenge right now, and especially on top of, even if you were surgical dentistry, but when you're talking about like teledentistry and something that's newer, it's even harder when you overlay that on finding the right people. And it looks like
I wanted to add to that too. But even with the school system, like since we partner with our school, they've had like 4 or 5 school nurses. So, when you want to educate the school nurse, but when you get on another call, they're like, oh, she's not here anymore. So not even just the dental team, but just the school system, they're having shortages as well of teachers, social workers, and nurses, which make it difficult for you to communicate with the parents and get those kids to be seen as well.
Yeah, thank you for me. So it's true. It's not just us. In dentistry, it's every job sector. But we've been joined by Jackie. Hi, Jackie. Jackie, if you could unmute yourself.
Yes, sorry, I was here the whole time. I just wasn't sure what the etiquette was with.
Yeah.
Virtual.
Oh no, don't worry about it. So it's all good. You're with us now, and so this could be a good thing or a bad thing, but we're going to catch you up. We actually had like extra time because we didn't have any Q&A, so we had an extra 20 minutes. So we're all good on time. So are you okay if I ask you like 4 questions in a row?
I would love it. Yes, it's been a wonderful discussion.
Okay, I'm going to ask you 4 questions in a row, and then we'll go back to our round robin thing. Okay, so first, Jackie, if you could go ahead and please describe your teledentistry program.
Right, thank you. So I have several teledentistry endeavors. I'll specifically talk more about 2 because the others kind of overlap with what people have been talking about so far. So one of them is that I do, just as background, I'm a pediatric dentist and I'm a health services researcher. And so I mostly research, 80% research, and I've been funded by private foundations and the NIH. And so when I look at this, I'm really concerned about the outcomes being measurable and knowing, are we actually doing good work in a way that we can, that is reflected in what the people are telling us who receive these services, and also in our own satisfaction and what we're always looking for, which is actually health outcomes and dental use. So all of the work that I do is considered research. So the one that I wanted to talk about, which kind of hasn't been really mentioned on here, is I do virtual infant oral health education. And infancy is such a critical time to talk to families and reach families and get the information that families need to keep their child healthy and set up healthy habits for the whole life course. And if we can get the right information to families in the comfort of their home or in a way that works with their own schedule, then we are really ahead of the curve, or at least giving the child and the family a chance to be cavity free. And oftentimes when we wait till the first dental visit, it's too late. Children have had teeth for 6 months, or the families have already had cavities, and we need to go in the operating room at that point. And so I really try to get to the families as early as possible. And we found, especially in the pandemic, that the best way to do that is virtually. And so we do virtual infant oral health education with families, and we do a porch drop off. And then we do basically what you would do for the first dental visit, which is educational, but through Zoom. And we use the baby oral health program, which is based out of the University of North Carolina, which is kind of a flip book, but I guess virtually. And you can just use 1 or 2 of the slides. We could just focus on diet and fluoride. What is fluoride? And then we can tailor it to the family and what's going on in the home. If there's like 5 kids and things are a little chaotic, or if the mom has more time, or she's able to focus because there isn't a lot going on. So we could do longer or shorter, but it starts with this very codified oral health education, and tailored to the mom, and then we open it up to the mom and we say, what are your questions? What's going on at home? And oftentimes they'll show us in the home what's happening. But we'll go to the kitchen with them. We'll go to the bedroom and the bathroom and see how things look. And the questions will be asked. And we can also even do an oral health screening of the child, if the child's awake or not napping or available. And then the outcomes for that study, which is funded by RK Mellon, is feasibility and acceptability. Do the families find this helpful? Are they comfortable disclosing information about their child and their family? Are they concerned about privacy, doing this in the home? And was this the right time? Was this the right way to get to them? And of course, we have a porch drop off and we have our advice afterwards, and it's tailored to them, and we can email to them or text to them as we did the consent. And it's it's based on motivational interviewing. So for each thing that we discuss that we want to work on, how motivated they are to do each one of those. And of course, we always try to link them to a dental home, but not just that, social services within the area, whether it's Early Head Start or WIC or TANF, or we have a whole team of social workers plus the university and a community engagement center to back us up. And we really use oral health as a vehicle to get the family many services within the community. And so they see oral health within the larger context. So it's wonderful to do this work and then really get outcomes on what specifically about the program is working for the families for this infant oral health education. And then we've had a very high success rate at getting families into the dentist.
So I just want to clarify for the audience. So this work's all being done through the University of Pittsburgh, right? Dental school?
Yes. Well, so I'm a faculty member at the University of Pittsburgh on tenure track, and this is one of my community-based studies. Mm-hmm. So one of the community-based studies is the feasibility and acceptability of virtual infant oral health education for families in low-income neighborhoods that are seen as more vulnerable. And one of the outcomes is whether they get a dental visit and have dental use after participating in this study. So another one that we do, oh goodness, well, there's a couple of them, but and as an adjunct to this, I also do interprofessional oral health education. So medicine, dentistry, nursing, and social work. And then they learn how to do this first visit with a family. The ones who are healthcare providers also do Smiles for Life and learn how to put fluoride varnish on. And then they shadow this visit in the home to learn more about social determinants of health and community, and be a good clinician in community. Because what's great about these home visits, essentially, virtual home visits, is it's never really about teeth. If you ask about the nighttime routine of toothbrushing, you get into, oh goodness, all issues of who's at the home, who's working, what's the family structure, socioeconomic status, sometimes even domestic violence, opioid disorders. Everything is related to what happens in the home and who's in the home and who people can trust to take care of their children. And then those have to be addressed before we can address the toothbrushing, because that is addressing the toothbrushing. And so seeing it in that larger context and knowing that we have to support the whole family in order to support a nighttime routine. And that is what we're here for, and that's what we're prepared to do. And seeing if that type of conversation, which is not a conversation we often have in the dental office, or have time to have in the dental office, but this is, of course, more important for the family and for the child, then in my opinion, most of what I do as a clinician when they see me in person. So this first visit is key to setting up what oral health is and what it can look like and what the possibilities are and what our goals are for this child and how we can help the family to do what they can do, to make small changes as they can and stay connected for the family. And then, of course, having the trainees participate also helps them learn how to have these conversations and see oral health as part of general health in all of the work they do as a nurse practitioner, as a pediatric medicine physician, or in social work, and how they support their families and their clients, and including oral health in part of the social services that's necessary to support the family. So virtually, I think this has been phenomenal. We originally did this project based in a community center, and people would come in with their children, and we would do what I would do more as a clinician, which is look at the teeth, talk about diet, talk about hygiene, talk about visiting the dentist, schedule them the first dental visit. And I would say that's, what we always do, it's very traditional, but it really didn't have the same impact at all. We didn't have the same conversations as you would have in someone's home, talking to them one-on-one in their bedroom, about like what it's like to do nighttime routine and what's really going on in the home and what's really going on in the family. And, that's when we really get into what the family needs. So that has been fantastic. And each of the families gets $50 for participating in this. And then, of course, all our support and services and a porch drop off of everything the child may need, whether it's teethers or toothbrushes, lots of game stuff, healthy food activities, and a lot of resources about fluoride and healthy drinks. I love healthy drinks. And how AAPD, and AAP and everyone works together to come up with those recommendations. And it's very confusing to families to know what should my child be drinking at this age. So just being able to answer all of those questions and have enough time to do it and be in a space where people can hear it, that has been something that has really moved me as someone coming from a very clinical background to being very much doing community-based and community-based participatory research and almost social work, and that's been fantastic. So that's one of the studies. Another of the studies that I do.
I'm
Yeah.
sorry. I'm sorry.
Yeah, go ahead for the questions. We can just stick with that one. We can just stick with that project.
Well, yeah. So going back to the first project that you mentioned.
So that is just, I think we only did one. Yeah, we just did one project.
Which is the
Yeah.
infant oral care
Yeah.
visit one, which is, like I said, so interesting. And I guess for the audience goes back to what I said about how much of dentistry really needs to take place in a brick and mortar office. If you could, like, talking about that project, can you talk about like two or three things that have been that you think are key to that project being successful? And
Yes.
the outcome you're talking about.
Trust in the community, right? So if we're doing community-based recruitment, you need trust in the community that this is something that the moms feel that they need. So before any of this can start, it has to be something that is requested by the community and delivered in a way that is accessible. So for example, the sign up can't just be on a website because that already eliminates equity. It has to be something that people can access in any way with whatever they have to access it. So, we need a steady phone, we need a steady coordinators, program managers, people on the ground who can sign people in person or in any way that it was possible. Going to daycares, going to the community centers, making sure there's word of mouth. So we have like 5 community partners, all of which help with recruiting and vouch for us that we are safe people. We're not going to be scary. And a lot of people are afraid of anything dental. So this is an easy way to touch bases with dental that isn't scary for the family. And we can eliminate some of that fear right off the bat. And a lot of people are afraid of bad news in their mouth or their children's mouths. So, it already starts with, everything looks really great from here, and let's keep it that way before things start happening. So, we do birth to 3 for the children. So if we can catch them early enough, nothing has happened in their mouth yet. And we can keep it that way. And we can put it in the historical context of the community. So one of the communities that I work with has had a lot of advertising by soda companies in that particular neighborhood by celebrities who are Black, speaking to the Black community. And we can specifically talk about how soda and has been disproportionately advertised to the Black community and why, and the history of that, and if we want that for our children, and how to think about those advertisements when we see them now that we know what's going on. And and those conversations help with trust and help with understanding the larger context for oneself, and really help like everyone realize like this is so much bigger than just teeth. And we're right there with you, seeing how hard this is, and we'll do what we can to support any way we can, because this is twice as hard. And just putting in the context of what the words would be like in the community to gain trust that we're working in. So, I do love community-based work because we can both recruit from community members through trusted relationships, and then we can use even more trusted relationships to get families services that might be helpful. And link them to a dentist that I trust, then maybe they'll trust too. So there's a lot that goes on there that has to happen to get to that first dental visit. And I feel like we're finally making a dent because of teledentistry. There's such dismal rates of first dental visit at age 1 across the country, and disproportionately worse numbers when it comes to communities that are vulnerable. So if we can get the communities who are vulnerable to find a safe and trusting and vehicle to get to that first dental visit at the time that's needed, we are really doing a service. But more importantly, getting the information to the families to keep their child's cavity free, because a lot of times, even if it's part of the guidelines to give that information at the first dental visit, it often doesn't happen. So this is, in my opinion, more important than a lot of that, the first dental visits that can happen across the country.
So I'm curious, because the next two questions are about challenges, and I'm kind of curious if, because you are in the academic setting, you may have had different challenges than what you may have heard the rest of the panel talk about. But can you, in your mind, think of like what has been the biggest challenge that you were able to overcome in order to get your program going?
Right. I would say trust. And so we did that in multiple stages. The first thing I did was a community-based survey by trusted community partners. I had them tell me oral health was one of the number one priorities of the people in their programs. And they have been working for 25 years in these communities. And once I could gather all of that and put that together, I created a memorandum of understanding with all of the community partners, including the dental clinics, to show that I was not going to take their market share, that I was providing infant oral health education, and I would not be billing for services that they could then not bill for. So building trust extended into all areas of the community, including the healthcare providers. And that took 2.5 years, to build trust first and become part of all of the steering committees in the community for early childhood, to become someone that everyone trusted so that they would advocate for the program. So I think trust is the number one challenge that was required in order to be overcome. And you think, we're just talking about oral health. Why am I helping with vaccines? And why am I helping with Zoom funerals? And why am I helping with all these other things and using the resources in the university to help the community? And it's because it's essential for any program to occur in community that has trust. It's that I'm not just concerned about my goals, which is to keep children healthy, but I'm also concerned with whatever the goals are of the community. And if the goal of the community right now is to help with virtual school, then I will help with virtual school for 3 months, because that's important and the kids need that. So all of these things are huge challenges to build trust with oral health in general. But once I build that, then I can hopefully spill that over to the health care providers who provide dental services. And I can say that I've trained them in infant oral health, and they will be giving you the same information, not different information that's confusing. And we will all come to you in a united front to help support you and your child. And that is essential. So building trust with community members, we will trust community partners, having a legal basis as a framework for that trust to have a foundation, and then training all of the healthcare providers to then be on board with the same information, so that we can give a cohesive message to the community that we are trustworthy and we are going to help the families and give them not confusing, disconnected information. So teledentistry in this case is very much linked to non-teledental services. And it has to, in my opinion, for it to be effective, or else we aren't working together. We'd be working against each other. And my goal is to get them to the brick and mortar.
And what have been some of your continuing challenges?
Yeah, some of the continuing challenges are scheduling, because I have 2 pediatric dentists who do these virtual infant oral health education things. And then we have the families who may be working 3-4 jobs. And what's great is we let them do this as many times they need for the child. So that they can do infant oral health education with mom, and then they could do it with an uncle or a grandmother that's helping care for the child. Because what we've really learned in this, by meeting people in the home, is that usually more than one person cares for the child. Usually it's a host of people: grandmother, uncle, sister, neighbor. And if all of them don't believe the same thing or have the same values for oral health, then it's a really big problem, because you only need one caretaker to be giving soda all day for the child to get cavities. And then it can cause conflict as well between the caregivers who want to promote oral health and then the caregivers who don't. And the last thing we want to do is to cause interpersonal conflict related to a child, which actually can be a barrier to the child getting the oral health they need. So we can do this multiple times with multiple people in the family, but scheduling that can be very challenging, because we oftentimes these are on the weekends or on evenings, awkward hours. So we have to have a healthcare provider, pediatric dentist, who's willing to do these calls at those times. And of course, I have grants to support the pediatric dentist time, as well as the grants to support the families participating. But that is another thing. I continually am soft money funded for these programs. So it's just, this one is 2 years. And then, towards the end, I will then go for follow-on funding and not go just for feasibility and acceptability, but then I'll start deciding if I want to go towards measures of healthcare behaviors. So if I want to include a knowledge instrument in my evaluation for the families. Oh, so I should mention my evaluation for the families. We also want to make everything easy, right, for the families. So the beginning is, our slides, slide or a few slides. Then we do the mom's questions, which is the bulk, of what we do. And then we may have an oral health screening of the child. And then the last part is the evaluation. And the pediatric dentist will get off, and the program manager will then open up the Qualtrics on Zoom so that the mom can see and type in their answers. So they're being interviewed, but they can see that their answers are being reflected, and it builds trust as well. And right now our interviews may be 6 minutes, 7 minutes, a combination of obviously feasibility and acceptability of the visit and some sociodemographics at the end. But I would probably like to increase that to 15 minutes for the next phase of the study, and include oral health knowledge and oral health value, and some oral health behaviors. And then if I could, even a follow-up afterwards, and offer not just $50 for this visit, but then maybe $20 for a follow-up interview a few months later to see if any of these behaviors have lasted, and also be able to capture if they did continue going to a dentist, the dentist that we set them up with as the dental home. So a lot of my work is pre-work to the work that I think a lot of the people are doing on this call for teledentistry.
Well, and I want to, and thank you, Jackie. I also want to, again, comment on something that Jackie said, which is, and again, if in dentistry, we really believe in prevention, theoretically, right? And so but at the same time, most of traditional dentistry is end-stage surgical intervention. And so even when you're looking at, again, in prevention and what can be done with teledentistry, and again, as she said, in the home, because again, patients come to the clinic and they may tell you one thing about what they aren't doing. But when you're doing teledentistry in people's homes, you can actually see, and you can really see what is really going on. So again, thinking about that outside the box thing, like in terms of what you can do with teledentistry, we want to keep that in mind, again, if we're really going to what dentistry is supposed to be, again, which is prevention.
I want to give a quick illustration of that. As dentists and healthcare providers, we're always like, oh, you should brush your teeth. You should brush the kids' teeth. How many times do we actually have the mom or the parent show us how they brush the kids' teeth and tell them actually how to do it? And how often do we tell them when to do it or when to stop? Parents have no information on this. They come in feeling like they are failing a test they never knew they had. We're like, oh, you didn't get at the gum line. Well, no one told them to get at the gum line. No one gave them instruction on how to brush a kid's teeth at the gum line. But if we're in the home and they can show me how they're doing it and where they're doing it, I can teach them for the first time when no one's ever taught them. And I can answer these questions so they're never failing a test that they didn't know existed. They already know the information before they find out that there's in any trouble, that the child has white spots at the gum line, because they've known to brush at the gum line, because we went over it and we practiced and we demonstrated, and I was able to give feedback as they did it in their home on the couch, that they always do it every night. And that's a much more powerful thing to see how someone does it in the home, or to give you, or in the car seat, if that's where they floss. So instead of being like, oh, you need to brush, this is actually, in my opinion, a lot more practical, hands-on advice that they're asking for. And they've been yearning for this information with no one to answer them, or no one who has time to answer them, or no one who's in the right relationship. Like at the dental office, it might be too hierarchical to really ask, like, am I actually even doing this right? Or like, how are you supposed to do it? So I think if we meet families where they're at and not assume they know anything that we haven't been taught, if you just start asking families, anyone you work with, when do you think we should stop helping kids brush their teeth? You'll be surprised at the answer. A lot of people say like 2 years old, or 3 years old, they're starting to put their clothes on so they can brush their teeth.
I
challenge you for that. Yeah.
Well, I was going to say, I think in my 35 years of clinical dental experience, I pretty much heard every answer. Okay, so
Yeah.
we're going to circle back because we've caught up with we caught up with Jackie with up to the questions. So now we're going to start our round robin again with Erica. And so if I can go to the next question, which is, knowing what you know now, what would you have done differently in planning and implementing your teledentistry program? Again, starting off with Erica. Knowing what you know now.
We began our program in October of last year. So we're a very new program. We were slated to open in August, but of course, COVID pushed us back, right? Our initial paperwork and information to all the schools went out at the beginning of the year. I don't know how many of you guys have children, but at the beginning of the year, I swear these kids come home with packs like that of paper. I mean, the information, it was overlooked so many times. Parents were like, oh, you're doing what? You clean teeth in school? They're like, yeah, we sent it home. They're like, no, we didn't get anything. So, moving forward, that's not something we're going to do like that. If we have to do a whole separate mail home packet to every student, then that's what we're going to do. It's too much. It didn't work well. And that's one change we're definitely going to make in the future.
Okay. And then Dr. Kiana?
I actually wrote down what Erica said. That's one of our challenges as well. What I would have done differently, I kind of spoke about it at the on the last question, to just get the mobile van. I probably would have used all the money from our Duke endowment just to get the mobile van, because one, now the prices have skyrocketed for everything. And so the budget that we had in 2019 obviously is not accurate in 2022. And yeah, you brought up a great point. We need to restructure how we get the information out to the parents and to the students. We were heavily relying on the social worker because they kept having changes of the nurse, and they have that some kind of robocall, or that we were hoping that they would send out continuously. We're having to continuously remind them. We just participated in their parent university, and the parents had no idea we were even there. So we took that opportunity to promote ourselves. But we do need to find another way to get the consent forms and information out to the parents, especially if we're not able to go in person, because that was a big issue. We couldn't go in person still. They didn't know what it was going to look like coming back.
Mm-hmm. And Dr. Julie?
It's kind of interesting. I'm following Dr. Kiana, who wished that she purchased the mobile van. I, on the other hand, not really knowing what I'm getting into, and that the different modalities of teledentistry and mobile dentistry, I happened to have a very good opportunity that came to me right before COVID. No one knew that what we were getting into. And I got a huge loan. And at that time, it was a big challenge to me because I was just like a private. And it was just me, and that I had to kind of have a business proposal and business plan to a bank that I'm just happened to be a customer. And then I just had this great idea, and then, met with a banker, and then they fortunately approved it. And I got a loan and I purchased it, just not from any grant, not from anything, just a loan. And then 3 months later, COVID hit. And my goal was to get into long-term care facilities, elderly population, which has been in my heart for a long time. So I had to survive the COVID. So the one thing I can think about is, in knowing what I know now, that what I would have done differently, maybe not purchasing, the mover van right away, until that I knew that the population demands and in the communities I serve. But it's kind of double-edged because I had an opportunity because I purchased it, I also became very serious about pursuing this. And I felt like I'm on the edge of the cliff and I have to make this happen. And even if I have a great financial pressure that I have to pay off the loan on top of my brick and mortar business loan. I pursued relentlessly and digital marketing and I had to think a lot. I had to learn a lot. I read a lot during COVID, and I think that certainly equipped me. So kind of double-edged, that I wish I had not purchased so that during COVID, I did not have the financial pressure. But at the same time, that as of now, that I start to see more demands, and then finally that able to use it and go into the communities. So yeah, that's what it is. Yeah.
Yeah, I'm sure there's a lot of us that have things we wish we would have waited 2 years for sure. Dr. Jackie, what would you have done?
Yeah, sure. So, and I'll keep it really short. So, I created this program for families who didn't have a lot of resources. But what I found is that everyone needs this information. It doesn't matter if you make $1 million a year or like $20 a year. No one who has a kid actually gets this information before their first dental visit, and it's really hard to schedule their first dental visit. So I would not have limited my IRB, and I would not have limited the scope when I applied for funding to families who are low income. I would have made it available to everyone.
Mm-hmm. Mm-hmm. Well, if you have success with this, you'll be able to get more money. That's how it usually works. Okay. For our last question for the panel, and I want to take this opportunity to thank the four of you for giving your time to present, because this has been really interesting. Just to let the other people in the audience know, we did give the questions to the panel, but we did not go over their answers. So I personally am amazed by how different everyone's answer has been to the same question. There's been like almost no overlap, which is like fabulous. Okay, so to go to our last question. What do you wish we had in place from a policy, infrastructure, or technology perspective that would allow you to do what you want to do with teledentistry? Policy, infrastructure, or technology? And let's start with Dr. Kiana.
Okay. From a policy standpoint, Dr. Bryan's doing a great job with North Carolina Oral Health Collaborative. I'm from North Carolina. The reason why a lot of dentists want to move here is because of you got to be a dentist to own. You have, we love all of that. And so he's taking it slow with us. I guess I've been in 11 years now. Am I an old timer yet? I don't know if I'm an old timer yet, but he's taking it slow with our mentality here. He's opened up for the hygienists, the local anesthesia. Now they can do it on their own, and the change to the public health hygienist. So I think that's a great foundation for us to start, and then we can build on that. As far as infrastructure, at FQHCs, if you don't know a lot about them, a lot of them started out as free medical clinics, things of that nature. So a lot of the C-suite, if you haven't heard that terminology, or administrative staff, your CEO, your COO, a lot of them know a lot about medical. They don't know anything about dental. And a lot of times they get a dentist in there and we're gung-ho, we're ready to go. Some of us come from private practice where when we say what we want to do, we do it and it gets done. And that's not the case. So in public health, it can be a little bit slower. I have learned that's a good thing because it makes you think out process, workflows, pros and cons of what you need to do. So it's good to slow down, but I would love to see more emphasis on some of the things that North Carolina has opened up as far as the clinical dental health coordinator. I got my team certified in that, but there's not a tangible, there's job descriptions, but they still don't see the value of it. And the way I try to educate the C-suite is like, they're no different than the nurse navigators. They're doing the same thing, but just trying to push that forward, because everything that you've heard here, social determinants of health, if you haven't heard this in the news, especially when they're talking about how much money they want to give to community health center, the administration. And when I say the administration, the Senate, the Congress, when they're voting on all of these issues about healthcare, social determinants of health, who gets it, it all goes into one. And so that dental health, that clinical dental health coordinator is that missing piece to make these appointments with the parents, with the grandma, with auntie, whoever is keeping these kids and helping them get to their appointments. Also, access to social workers. We have social workers in our community health center. And when I asked for them, they're so busy with medical. So we just need social workers that are either focused on both and looking at the clinic as a totality. And I think that's my biggest issue. It's like, we're still siloed. We're trying to come together, but some of those extra advocacy groups or community health workers that we've hired, they're specific for COVID. They're specific for medical. And so when you're looking at comprehensive care, is not encompassing that. So as far as infrastructure, those are the two things that I would love to see progress in oral health, especially with the community health centers. Technology, the platforms are growing. You have MouthWatch. Right now we're using DoxyMe. We just felt like for us, we just needed something real quick and simple because there still was a technology literacy with our patients. And so I know that's going to continue to grow. So, and also with the technology, integration of electronic health records. So your major hospitals, they are using Epic. That's almost a six-figure cost. Dentrix, that's a six-figure platform, but they don't want to talk to each other. So it's consistently, and then when you're working in public health, you need statistics, you need reports, and Dentrix is okay sometimes, but Epic really gives medical all the statistics they need, how many patients they see, what demographic that were they in, what background as far as race, culturally background, economic background, they get all that stuff so easy. And it's hard for dentistry. A lot of times those are the numbers and the statistics we need to continue to fund dentistry and to fund these oral health programs. So technology, more integrated platforms, and more infrastructure is what I'm looking for.
Mm-hmm. And Dr. Julie?
Yes, actually, Dr. Kiana, that mentioned a lot of things that has been in my heart as well. So I will try not to kind of overlap what Dr. Kiana already mentioned, but we'll add a little bit about the more philosophical, but at the same time, like more practical, can be practical, that way of, addressing this question. So first of all, I want to say really thank you, that for the audience, that I have a very limited knowledge about the what organizations that you work for or you own, or medical or clinical or admin. I do not know, but I know you are here because you see the value of that sustainable oral health in as important part of systemic health. So thank you, for coming. I think that's just very encouraging to see the audience in this telehealth regional conference, that we can be connected and work together to make a difference in this, that effort. So a couple of things I want to mention is that, that we talk about the public health and the private, and it's kind of hard to find the private sector are very actively working on this area. For me, I'm a little hybrid because I worked in not-for-profit, healthcare management, public health, clinical, academia for a long time before I jumped into this private practice model. In my heart, always it has been that whatever public health program that we are doing, it should make some, good, practical, good business model. We cannot just have a sustainable public health program when we continue to lose money. That has been my, that with my business background, that always has been my mind. So that really working on this policy and infrastructure and technology, that they having the encouraging grassroots So, I'm just in the, one private practice owner, and, but I have a vision and I have a background, I have network, and I continue to work to, develop a good, practical, good business public health model in working with the community partners so that we can make a difference and that we can resemble other models, not just Northern Virginia where I am, but in Virginia and maybe beyond. So more holistic approach, medical, dental integration, and even, home visit companies, that like Dr. Burgett mentioned, that is a lot of things are social problem. And that only when we know what's going on in their lives, maybe we can better help them. And then the home visit companies, I try to work with them, has been quite difficult. There's no incentive and there's no infrastructure and there is no policy and technology. It has been difficult. So I hope that there are more, awareness, policy, infrastructure changes, and user-friendly technology so that we can work toward this effort.
Yes, thank you, Julie. And Dr. Jackie?
Yes, and I'll be brief again. I think we need to advocate for a CMS code for anticipatory guidance virtually under age 3. We have very dismal rates again for the age 1 dental visit, and that has been endorsed by the AAP, AAPD, ADA, all of the professional organizations for about 30 years. And we are going to continue to not succeed at this unless we reach the families in a way that they can get to a dental home. And I think that the way to do this is virtually, but it needs to be done carefully. So there are specific guidance on what constitutes anticipatory guidance virtually, or else it's subject to abuse and perverse incentives. So in the state of Pennsylvania, we have PHDHPs, so public health dental hygiene practitioners, and some insurance companies with the advent of teledentistry have encouraged age 1 visits or first dental visits virtually using the PHHPs, but it has been, to some people's opinions, abused and just a quick visit for 10 minutes to remind people to brush their teeth. And that is not anticipatory guidance. So I would love for a code that is reimbursable at a fee that does not encourage abuse, where it has specific guidance on a bundled service that happens, such as the domains that need to be covered, oral health screening, and linking to a dental home, similar to IMV, but without the fluoride in North Carolina, but done virtually. And I think if we had this program, then I wouldn't have to be relying on private foundation funding. And this could be given to all families, which all need it.
Yeah, and thank you. And before we finish up with Erica, I just want to highlight that really, in the system that we're currently in, our healthcare delivery system, whether or not teledentistry is going to go next levels is going to depend on payment, regardless of whether it's in the public sector or the private sector. And so then to close us out, Erica, what do you wish you had in place from a policy, infrastructure, technology perspective to do more?
Sure. So we've all said this, broadband has to expand. We have to be able to get everyone access. It's a health equity issue. The line is getting thicker between the healthy and the not healthy. And it's something as simple as the broadband. And there are federal dollars that are put forward to open things like school-based health centers that include a dental service. But there's not a lot. Only a few places are chosen per year. That funding would be a wonderful initiative to push for, to start prevention early with these kids. Tell them, a lot of them don't know. They don't know how to brush their teeth, just like you were saying, Jackie. This is a service that could really shape the rest of their lives. So having this early on it's critical. If we want to talk about really big P issues, the poverty level, the federal poverty level, it's set at an unreasonable amount. And then these people aren't able to get Medicaid because, they make too much, and that amount is not sustainable. And without Medicaid, they're not receiving services. And that needs to be adjusted. It's been too long since it has been adjusted. So.
I wanted to add, I knew about the broadband issue, but I didn't really know about it till COVID. One, the charter school that we service, they have 600 kids from K to 4. And they had to they luckily got a grant for Chromebooks. But I didn't, I have a desktop at home, but I had to realize, somebody tell me like everybody doesn't have a desktop anymore because they have phones. So they don't need to buy a desktop. They don't need to have internet at the house. So I don't think that was really exposed until COVID.
Yeah, a lot of children in our area were having to go to, they would have to do a, 10 to 15 minute drive to a local area to sit in the parking lot to do school because they didn't have access. And it's something that seriously needs to be addressed in our country.
So that's just another way in which COVID, has highlighted the structural inequities, which again, weren't necessarily directly health related, but have turned out, that in the end ended up impacting oral health also. I want to again thank so much to the panel, Doctors Julie, Kiana, and Jackie, and Erica for your time in participating, because we really all learned a lot. You all shared a lot. And like I said, you all are innovators and early adopters. And again, things may go up and down, but 20 years from now, you'll be proven to have been right in what you're doing. So now I'm going to go ahead and turn it over back to Brooke, I think. Brooke. I see Brooke getting up. Or is it Zach? Actually, no, it's. Oops, okay,
no, thank you. I'm gonna hand it over to Dr. Brian to kind of close us out. But I just wanted to say thank you to everyone for attending in person with us and virtually. I think that panel discussion was amazing. So much great information came out from all of your perspectives. So thank you guys for everything. And I will turn this over to Dr. Brian to close us out.
Thank you so much, Brooke. We'll see if we can get the slides to work one last time. Is everyone still awake with us? 20 more minutes left, but I think we'll close out a little bit early for you all. So before we dive in, just a few things I wanted to mention. I think the biggest impact that we'll make, right, is having everyone in this room sharing ideas, best practices about their program, lessons learned. And it's really important that we keep sharing. So there are a lot of innovative programs happening across the country, but people are unaware of them, right? And oftentimes, and particularly in public health, we are nose to the grindstone and we're doing our work, but we forget to reflect back and share some of those learnings. And so I encourage you all, not to let that exchange of information in today, at the summit and the session. Everyone should be able to access the attendee list if you made that publicly available. And I encourage folks to reach out and connect, talk, ask questions. Definitely ask questions of the panelists, ask questions of the other speakers. I think we had a really robust and engaging session, and I hope that you guys felt the same. But I just wanted to recap a few of the challenges, and I took some notes as well from other speakers, but we really are lacking payment regulation in particular. So as we know in dentistry, payment's going to drive innovation. One of the things that we're seeing, particularly in our state, and I've seen in others as well, is that the public sector payment system, such as Medicaid, helps to innovate and drive forward change in the private sector. So that might sound really odd, but you see it over and over and over again. So those that work with Medicaid agencies, when we're able to make changes in that system, then our private payers like Delta Dental, Blue Cross, Aetna, United, et cetera, pick up, right, the changes and start to implement in the private sector as well. And I think, Jackie, you made a really, really important point. We focus a lot, particularly at the Oral Health Collaborative, on marginalized communities and those that are most vulnerable. But the need for teledentistry and the need for anticipatory guidance, which you had mentioned earlier, and just basic education is not necessarily drawn across lines of income. So it's important that we also are reaching out and trying to build a robust system in our payment system in the private and public payer space. Digital literacy, we saw that over and over in terms of education. So the need to assist folks, to educate them how to engage in teledentistry. What does it look like? It sounds scary, right? I'll tell you a story, and I'm not trying to be funny, I'm being serious. In our state in particular, when we approached to make changes in our legislative environment to codify teledentistry, there was a question from a very educated person of influence in our state that asked, well, I'm not sure how that's going to work. Does the person just put their phone in their mouth to take a picture? And I asked them to repeat the question, and they were serious. They did not understand. They thought that the person would take their phone, physical phone, and put it inside their mouth to take a photo. I promise you that is not just in North Carolina, okay? It's not. I've had very similar questions asked of me from other state legislatures and across the country. So legislators are very confused what this means, and they rely on people like you in the room to help educate them, to demonstrate, to demystify, to provide the expert counsel that they're needing. So opportunities, obviously building infrastructure, I think knowledge sharing as well. So a part of demystifying is being able to demonstrate and showcase to folks how it actually works. What is the net benefit? And oftentimes for states, the reality is, what is the net cost savings? So I have not seen really a robust cost analysis done utilizing teledentistry, which I think is vitally important, particularly for our payers, to be able to see what they are going to be saving on the back end. So getting involved, a lot of this that I've already mentioned, but I think it's important to note again, you all have a voice and you're here for a reason, and we need you to raise that voice and start to educate folks. Because unless you do, you're busy doing your clinical work. And believe me, I call myself a recovering dentist. I do still practice clinically, albeit very infrequently. But you're busy doing your clinical work, which is really important and highly impactful. But don't forget to share those learnings and that expertise outside of the clinic walls, right? Or the mobile program walls, whatever walls those are, virtual. It's really important that you do that because people may not know. They may not think about how to deliver oral healthcare services the way that you have. And you guys are really definitely innovators. I mean, I've been really impressed by the programs that you all have built and how you've articulated both the outcomes, but also what your next iteration is. So continuous improvement, that's what I would say as well that I took away from today. Building trust, meeting people where they are, educating, community building, and making sure that you're always iterating for the next version that's going to meet the needs of the communities you're serving. So sounds altruistic, but it's really true. I mean, we get into this profession, I hope, for the reasons to help people. And the only way to truly do that is to listen actively and authentically to the communities you're serving. They will let you know and help guide you how to innovate. I was on a podcast recently and someone asked me, who's the number one innovator in oral health? And I said, the consumer of care. And they are. You have to listen to them because they're going to share with you their barriers and then help you co-design, I hope, how to best serve them. So we're here to serve other people, not ourselves. Consider leadership opportunities. State boards are always looking for the next generation of folks that can come in and continue that mission forward. Don't be afraid. They're not scary, I promise. Some of them are, but not all. But really get engaged with them. Go to meetings. Try to build thought leadership on your own. You can do that as an individual. Write blog posts. Go to social media. Write about your experiences. And if you take one thing away, please don't keep what you're learning closed in a closed system and not share it. Because that's what we see often in large health systems. It's proprietary, it's IP they don't want to share. And then how are we going to grow and learn together and collectively? So make sure you're sharing with others what you learn. And don't be afraid to fail, because we all fail, and pick right back up and move forward. So lessons learned, again, I'm going to take it back and close it out in policy because that's the area in which we work primarily. But demystify and demonstrate. So you have to be able to show. Teledentistry is something that is very confusing to folks. They don't understand. I'll take you back. Do I put the phone in my mouth to take a photo? Well, no, you don't do that. But what do you do? How does it work? So help them understand by showcasing exactly how it works. Because once they see it, it's not as scary, right? It's not as difficult as what they might think. The barrier to entry in terms of equipment and software is low. And really, we've been doing teledentistry, and this is what I say often to a lot of our influencers. People have been engaging in teledentistry, not calling it that, for decades and decades and decades. But now we are formalizing it, which to Dr. Hilton's point earlier, it's going to take a while. So we really went full force during COVID. Things are starting to retract back or try to be pushed back to pre-COVID. Don't let that happen. So keep pushing forward, keep sharing. And the only way to showcase is it is safe, it's cost effective, it meets the needs of our communities. Patients love it. So when you do that, you help kind of push the narrative forward where it cannot be reverted back. And then policy reform doesn't equal implementation, and that involves the payer system as well. One thing that we learned early on is the policy is just really the tip of the iceberg to get accomplished. How people use it and that they even are aware of what is allowable in their state is a whole nother issue. So there are people doing things that are not allowable in their state, and there are people that are missing opportunities because they think that it isn't allowable in their state. So don't be afraid to ask your local dental society or your state dental society, is that allowed? Ask your state board, is that allowed? Ask advocacy groups such as the Oral Health Collaborative or Virginia Health Catalyst, and there's a plethora, there are 39 of us across the country. Ask your coalition, is that allowable in our state? And band together, start building out these programs and iterating and getting thought partnership from others. So I love this because I think this is so true when it comes to policy. And Kiana, thank you for the kind words, but we are moving very diligently and strategically in our state. You heard her say, we finally got hygienists to be able to administer local anesthesia. Well, that happened 50 years ago in the first state, right? So we're 50 years behind, but we are making progress. So balance, your passion with action and be pragmatic. So you can't come in and say, I know this is the right thing to do. We have to change this policy. And payer, why aren't you paying for this service? Do you not care to reach underserved communities? It's not that they don't care, but sometimes that's not top priority for them. So get to know them. What are their top priorities? And then start to weave in how teledentistry would help support their other initiatives. Because that's the thing people don't understand, right? They think teledentistry, again, phone in the mouth, capture a picture, send it to somebody, they bill for it, and then they think abuse, abuse, abuse. That's what they think. Been in enough closed meetings with people that say that's the slippery slope. That's the favorite phrase of folks, right? But if you can showcase programs that are working, that aren't being abused, that are cost saving for the state, and really doing good for the communities you're serving, it goes a long way. So I love the quote, pure pragmatism can't imagine a bold future, but pure idealism can't get anything done. So again, it is a balance. So you have to be able to balance what you know is right and what you want to do with where people are currently and make incremental change. So get involved, know the landscape in your state, know who your players are, start having meetings with them, showcase your program, do an open house, do it while you're live with with patients in the clinic or in your mobile setting. Invite your local legislator to your community-based oral health program. Say, I want to show you what happens in a community-based site in an oral health program at the school and why this is important for your constituency. Because they really just don't know. So there are a couple of resources I wanted to point you all to. We have an advocacy toolkit in North Carolina that you can download. It's free. It's not specific to our state. It's applicable and the principles can be applied across all states. And then we did also publish all of our process in the best practices guide from the Association for State and Territorial Dental Directors, or ASTDD. So you can download that as well. So I'm going to skip through some open questions here because I get the sense you guys are really tired. Yes.
So there was a question in the chat that we didn't get to.
Okay, excellent.
That was maybe last few minutes.
Yeah.
Might be able to answer.
Okay,
Let's
do it.
If your slides have not been taken, like 20, but.
Weird.
So.
Yeah.
Your resources can still be, doesn't still access these slides from the portal. But the
Mhm.
question that we wanted to go back to was, it's the one about unintended consequences of competition by teledentistry. It seems like
Yeah.
high revenue services like teeth straightening are being poached by telehealth services. Worry that lucrative services will be picked off by teleservices and local providers will be left with what's left.
So I do know this is recorded again. I'm going to go back to that. So I'll give you the quick take of my personal opinion. This does not mean it reflects anyone else's opinion. There are bad actors, okay? There will always be bad actors, no matter what. There are people that are utilizing teledentistry to abuse the modality. But that's a very small fraction of people that are using the service and the modality. Am I afraid? No. And the reason why is because there are so-called things of standard of care, and there are regulatory agencies, which are your boards of dentistry in each state, that is what they should be exploring if there are complaints. If you, and I know this is where I think it gets difficult, when you see, sorry, there are plates going in the background, I don't know if you can hear that. There are times where it's very difficult to report something that you see because you feel uncomfortable. You may know the provider. Talk to the provider, make them aware of what you're seeing that you're concerned about. There's always 3 or 4 sides to a story, right? If you see something persistent, it is an obligation to report it. And so we do have an obligation, again, because who are we serving? The community, not ourselves or not our profession. We're serving people utilizing our services. So I'm not really worried about it in the sense that, do I think it's going to take over and create this monopoly? No. Do I think that lawsuits will continue to come down and be placed in front of state boards? Yes. The question, I think, goes back to something very specific, but I don't want to talk about that specific company. But I've seen lawsuits happening state after state from trying to preclude that company from utilizing teledentistry services to offer their service. So I would say continue advancing quality care through teledentistry, continue discussing the concerns if you see them. But again, we're not the person or people, right, that has to ensure that the market is tight and locked down, because that's also not good to impede market competition and free market. So if there's something that you feel is not quality, report it. But that's why there are regulatory agencies such as the state boards of dentistry. That's my opinion, but I'd love to hear your all's opinion.
As far as companies that are doing those type of practices, I mean, there's a patient for everything. And I agree with Dr. Bryan. If you are giving standard of care and you're sticking to your guns of how you want to treat the patient, then you shouldn't have to worry about those other companies. That's all I have to say. I mean, yeah, just don't worry about them.
I did want to add one thing to that, is just if you are the patient's provider and you don't feel that the service that is being offered is quality and you have an objective reason to believe that, you can say that, right? That's why we have a license and free will with our patients to make joint decisions together. And I will sometimes say, I would try to steer you to this particular option in your care plan versus another. And let me explain why. But at the end of the day, it is their mouth, it is their body, and you are there to help them make informed decisions, but they can make whatever decision they want to make. And you have to respect that.
I want to add to that, just to give you an example. I had a patient who went to their home country to get ortho work done. So it's not always just the companies or mail by order companies. It's sometimes patients going to back to their native country and getting work done. And so this particular patient, first time seeing them, they had ortho, and I have a lot of patients that choose to go back home to their home country to get their work done. The way that I like to educate them, whatever you do, this is what I want you to look for. It's your right to look at your x-rays. It's your right to look at this, because they don't think they have the rights to look at their information. So it's all in how you approach the patient as well. If they want to go back and get a root canal at home, I show them what a healthy root canal looks like. I said, if your root canal looks like this is not healthy. It should look like this. You should see this white material go all the way down the root of the tooth. I explained to them, what is the root? What is the top of the tooth? So, but even mentioning about the patient who still needed to go back, I said, well, I suggest that when you go there, and I gave the patient education on how to advocate for themselves and what they needed to do for themselves when they go back. I couldn't do anything for the patient in my chair. They were planning on going back. And so that's another way that we can approach it too. You can still educate the patient, because sometimes they don't know that what they're doing, but they are grateful of what you tell them, and not making them feel ashamed for the choices that they are making with their body. I'm just here to give you the information.
And I want to add something. I think the question was mainly about the lucrative. That so if some selected, aggressive companies take that lucrative kind of a part of that dentistry, and then what's left over is, I think that was the part of the question. And I think that we really, and that's one of the reasons why we want to really work together and work hard not to have the tainted reputation about using technology just for the lucrative, because we are serving, like Dr. O'Brien mentioned, we are serving people, with a quality of care. So I'm not kind of worried about it, but I think we need not to be lazy, and we need to work hard at expanding the pie so that we can use this modality to expand care. And I think there's plenty of lucrative, that the things we can do.
Thank you so much, Jackie. Yeah, absolutely. Well, wanted to leave with one last thing as we close out. And so Irene, Dr. Hilton made a great point that I just want to reiterate, and that is the flexibility of teledentistry. I was also really happy to see that all the responses to the same question were different and varied, because you're utilizing teledentistry in different ways. And that's what's so beautiful about teledentistry. It's not a one size fits all approach. Like, you can innovate and truly feel that you have flexibility to do that within the parameters, right, of your state laws. And so I encourage everyone to get involved. Please don't hesitate to reach out. I will make sure that the slides are available to you all. My email and cell phone number is listed, but if you have questions, don't hesitate at all to reach out. But thank you all for such a great session, and another round of applause, and thanks to the panelists and the speakers. I will clap. All right. You guys have a great rest of the weekend, what's left of it, and great start to the rest of the summit.